next topic is central nervous system or CNS. In this CNS, we will start with the neurodegenerative diseases. So, three important neurodegenerative diseases. One is Alzheimer's disease. Second is Parkinsonism. And third is multiple sclerosis. So quickly covering, for Alzheimer's disease, there is a decrease in acetylcholine in the brain. So we want to increase acetylcholine. So we use acetylcholine esterase inhibitors, as we remembered from Dr. Govind, DRG, donepezil, rivastigmine, and galantamine. Then apart from this, we have an NMDA antagonist, which we can use, memantine. And the third drug which in Alzheimer's disease which has been recently approved is a monoclonal antibody, which is aducanumab. Aducanumab. This is the only monoclonal antibody used in Alzheimer's disease, or only drug used in Alzheimer's disease, which inhibit the basic disease process, inhibit the cause, we can say disease modifying agent. It inhibit the fibrils which are present in the Alzheimer's disease. So from the name you can remember it is monoclonal antibody which is used in Alzheimer's disease. Then multiple sclerosis, several drugs are being used, like we have beta interferons, fingolimod, dimethyl fumarate. We have drugs like natalizumab, and the latest monoclonal antibody which is approved is ocrelizumab. Now, what is important to remember, beta interferons are usually the drug of choice for relapsing remitting multiple sclerosis, the most effective drugs, whereas ocrelizumab is a new drug which is a monoclonal antibody against CD20, and it is the only drug which is effective in primary progressive multiple sclerosis. Okay. Then coming to Parkinsonism. In Parkinsonism, there is imbalance between the dopamine and acetylcholine. In the brain, there is normally dopamine and acetylcholine levels are balanced in the basal ganglia. In Parkinsonism, there is degeneration of dopaminergic neurons which lead to this imbalance. So for treatment, either we have to increase dopamine or we have to decrease acetylcholine. So two type of drugs we can use, one which increase dopamine and second which decrease acetylcholine. So the drugs which increase dopamine, so if we see, this is the normal synapse, dopamine is produced and stored here. So it is produced from tyrosine which comes inside, which is converted to dopa, and dopa is converted to dopamine. Then dopamine is stored. Whenever nerve impulse come, it is released. Then it work on the receptors. And after that, this dopamine is metabolized by an enzyme called as monoamine oxidase or catechol orthomethyltransferase. So this will break dopamine. So in Parkinsonism, we want to increase dopamine. The options we have are, we can give levodopa, which is precursor of dopamine. We can give drug which increase the release of dopamine, drug acting here, which increase the release of dopamine. We can inhibit metabolism, and we can give a drug which stimulate the receptors. The first drug which we use is levodopa. Levodopa. It is the most effective drug for treatment of Parkinsonism. But if you see, this is our brain. Brain is covered all around by a blood-brain barrier. So if we give levodopa, it can penetrate the blood-brain barrier, enter inside the brain, and in the brain it is converted to dopamine. That will treat Parkinsonism. But it can be converted to dopamine outside the brain also, and this dopamine cannot cross blood-brain barrier. So we have two problems. One, when we give levodopa, only very few amount of around 2% will enter the brain, so efficacy will be lesser. Second, the dopamine which is produced in the periphery will start causing side effects. It will start acting on D1, beta 1, alpha 1, causing hypotension, tachycardia and hypertension, as well as acting on CTZ here, which can lead to vomiting. Second, efficacy is low. So what we found is the enzyme which convert levodopa to dopamine, which is dopa D carboxylase, if we inhibit this enzyme by another drug like carbidopa and benserazide, then more amount of levodopa will enter the brain. That will increase the efficacy, as well as it will decrease all these side effects. So we commonly add levodopa with carbidopa or benserazide to avoid the peripheral side effects. But amount of dopamine in the brain will increase. So the central side effect, the dopamine which is causing side effect in the brain, like it can cause psychosis. Remember psychosis and schizophrenia, same thing. They are opposite to Parkinsonism due to excessive dopamine in the brain, like abnormal movements. They are manifested by abnormal movements, dyskinesias, abnormal behavior. So all these side effects, they will not reduce by adding carbidopa. Other side effects will reduce. Okay. So we can give levodopa. Then second, we can give drug which release dopamine, which is amantadine. Amantadine. So amantadine, special point to remember, it is the only drug in Parkinsonism which do not cause dyskinesia. Rather, it is used for treatment of dyskinesia because of its additional action as an NMDA blocker. Amantadine is NMDA blocker, so it can be used for dyskinesia treatment. Amantadine, the main side effects include ankle edema and livedo reticularis. Livedo reticularis. Then third drug we can use are MAO inhibitors and COMT inhibitors, and the drug we can use are MAO-B inhibitors. MAO-B inhibitor like salazilin, rasazilin, and a new MAO-B inhibitor called as safinamide. Then we can use COMT inhibitors like entacapone. Another drug we used earlier was tolcapone, but because it was toxic to liver, that means hepatotoxic, so it is not used nowadays. Then lastly, we can use the drugs which stimulate the dopamine receptors, and the drugs acting as dopamine receptor dopamine agonist, they may be ergot derivatives like bromocriptine and pergolide, or they may be non-ergot derivatives, which are the newer drugs like pramipexole and ropinirole. These new drugs are now the drug of choice for Parkinsonism. These are drug of choice. Remember, most effective is levodopa, but levodopa has plenty of side effects, so these are now drug of choice. Apart from Parkinsonism, these are also drug of choice for restless leg syndrome. Okay, so this is about the first group, the drugs increasing dopaminergic activity. Then second group, we can decrease acetylcholine. So anticholinergic drugs which act in the brain, they are drug of choice for drug-induced Parkinsonism. They are drug of choice for drug-induced Parkinsonism, and we have two type of drugs. One which are central anticholinergic drugs like benhexole, also known as trihexyphenidat, benztropine-like drugs. Then second, we have first generation antihistaminic which have very strong anticholinergic activity and can enter the brain like promethazine. So these can be used in drug-induced Parkinsonism. Okay, so that is important about the first topic in the CNS, which is neurodegenerative diseases. Then second very important topic in CNS is anti-epileptic drugs. We know epilepsy is due to stimulation of brain. So for treatment of epilepsy, we need to depress the brain. The options we have are, we can increase GABA, we can decrease glutamate activity, or we can block calcium channels or sodium channels in the brain. The four main mechanisms: sodium channel blocker, calcium channel blocker, GABA increases and glutamate decreases. So discussing these one by one, drugs which increase GABA. So first of all, how GABA works. So we know GABA is produced and stored here in the synapse. Whenever nerve impulse comes, it is released. Then it will act on the channels. Remember GABA benzodiazepine channel, which will mediate the entry of chloride. So it will open that channel. That will lead to depression of brain. But after some time, this GABA is metabolized. So this GABA, it is either broken down by the enzyme GABA transaminase, or it can get reuptaken with the help of a transporter known as GABA transporter 1 or simply GAT1. So what are the options how we can increase GABA? The first option is we can give a drug which release GABA. If GABA comes down, it will start producing action. Second, we can inhibit GABA transaminase. Third, we can inhibit reuptake. And lastly, we can stimulate the channels. The first drug which act by releasing GABA, these include gabapentin and pregabalin. These act by releasing GABA, and these are drug of choice for diabetic neuropathy and post-herpetic neuralgia. So basically neuropathic pains, they are drug of choice. Then we can inhibit GABA transaminase. The drug which inhibit GABA transaminase is vigabatrin. Vigabatrin. The name says everything. The name says it is GABA transaminase inhibitor, and the main side effect is visual field defects. It causes visual field defects. Visual field defects, contraction of visual field is seen, and the IN says it is used for treatment of infantile spasms. It is used for treatment of infantile spasms. Now, infantile spasms. What are infantile spasms? As the name says, it is seen in infants. So what type of spasms are these? These lead to sudden flexion of the forelimbs, like sudden flexion of forelimbs. It look like salam. So these are also known as salam seizures. Salam seizures. And it is seen in a syndrome known as West syndrome. West syndrome. The drug of choice for infantile spasms or West syndrome is ACTH, and the alternative drug is vigabatrin. If a person is having or baby is having infantile spasms with tuberous sclerosis, then the drug of choice is vigabatrin. Okay. Then third, we can inhibit the reuptake, the drug inhibiting GAT1. That drug is called tiagabin. Tiagabin. The name says it is GABA transporter inhibitor. It is a GABA transporter inhibitor, GAT1. So it inhibits a transporter which is GAT1, GAT1 inhibitor. Okay. Then lastly, we can stimulate the channels, and the drugs which stimulate the channels, they include barbiturates and benzodiazepines. Barbiturate we mainly use in epilepsy is phenobarbital, whereas benzodiazepines we use like diazepam, lorazepam, clonazepam. Benzodiazepines used in epilepsy. Now what is important is diazepam and lorazepam, they are used for treatment of status epilepticus. Both are used in treating the acute seizures also, and they are drug of choice for status epilepticus. In particular, lorazepam is drug of choice for status epilepticus. Diazepam is drug of choice for febrile seizures. Febrile seizures. Then the antidote for benzodiazepines is flumazenil. If there is overdose of benzodiazepines, the drug of choice is flumazenil. Okay. So this is first mechanism to increase GABA. Then second mechanism is to decrease action of glutamate. And we have two main receptors of glutamate. We have AMPA receptor and NMDA receptor. The drug which is inhibiting the action of AMPA is perampanel. The name says it makes AMPA nil. AMPA will not be able to work. And the drug inhibiting NMDA is felbamate. Felbamate is not commonly used because it causes bone marrow suppression. The name says BM means bone marrow 8. Bone marrow ko kha jati hai. So it is not commonly preferred drug. Then third, we can give calcium channel blocker. In the brain, we have T-type calcium channels, and the drug which block T-type calcium channel is ethosuximide. Ethosuximide, it is first line drug in treatment of absence seizures. Absence seizures, ethosuximide is first line drug. The drug of choice actually for absence seizures is valproate. If valproate is not in the options, ethosuximide is also drug of choice. Both are first line drugs. If both are given in the option, answer valproate. Then we have sodium channel blockers. The drugs like phenytoin, carbamazepine, topiramate. These are sodium channel blockers. Topiramate, it is used for many type of seizures, including Lennox-Gastaut syndrome. But topiramate has other uses also, which you can remember from the mnemonic comp. C for craving. It decreases alcohol craving. Craving of alcohol is reduced by topiramate, can be used in alcohol de-addiction. O for obesity. Topiramate is the only anti-epileptic drug which causes weight loss. It is used in treatment of obesity, FDA approved drug. Then migraine prophylaxis. This is important to remember. It is used to prevent migraine, not for treatment. The question is asked, topiramate is used to treat migraine. That is wrong. It is used to prevent migraine. And bipolar disorder. It is used for treatment of bipolar disorder. Okay? So you can remember the name says टोपी. अगर टोपी पहनी है तो कॉम की जरूरत नहीं है. Okay, so that is about the topiramate. Then coming to phenytoin and carbamazepine, they are used in treatment of focal seizures and GTCS, but they are contraindicated in absence and myoclonic seizures. They are contraindicated in absence and myoclonic seizures. Now, carbamazepine, the important point to remember, it causes auto-induction of metabolism. It induces its own metabolism. And carbamazepine, apart from epilepsy, apart from seizures, it is also used in trigeminal neuralgia. In fact, it is a drug of choice for trigeminal neuralgia. And it is also used in bipolar disorder. It's also used in diabetes insipidus. So, other uses of carbamazepine. Then coming to phenytoin. Phenytoin is very important drug because apart from epilepsies, phenytoin is a very strong antiarrhythmic drug. It is antiarrhythmic drug. Now, main problem is phenytoin has plenty of side effects, which you can remember as hot malika. Adverse effects of phenytoin: H for hirsutism and hypertrophy of gums. It can cause hirsutism and hypertrophy of gums. O for osteomalacia. T is teratogenic. It can cause fetal hydantoin syndrome. M is megaloblastic anemia by causing deficiency of folic acid. A for arrhythmias. It is antiarrhythmic drug. In overdose, it can cause arrhythmia, so it is a toxic side effect. L for lymph node enlargement. I for insulin. It causes decrease in insulin, which can cause hyperglycemia. K for vitamin K deficiency. If we give phenytoin, it can lead to vitamin K deficiency. And A for ataxia, nystagmus, and vertigo. That means cerebellar side effects. Again seen in overdose only, toxic side effects. So these are the important adverse effects of phenytoin. So we have covered 4 mechanisms, but we missed 2 important drugs. One is sodium valproate and second is lamotrigine. Both of these are having multiple mechanisms. They do not act by only one mechanism. They have multiple mechanisms, like they inhibit sodium channel, increase GABA, inhibit glutamate. So multiple mechanisms are there. Now lamotrigine, the main side effect is Stevens-Johnson syndrome or toxic epidermal necrolysis. Severe skin reactions are there. So due to this side effect, lamotrigine is always started in low doses and gradually the dose is increased. So to avoid these side effects, gradually increase the dose of lamotrigine. Do not start with the full dose in the beginning. Okay. Then valproate is highly effective drug. It is a drug of choice for most of the seizures, like it is drug of choice for absence seizures, drug of choice for GTCS also, grand mal epilepsy. It is drug of choice for myoclonic seizures, atonic seizures, as well as drug of choice for Lennox-Gastaut syndrome. So for most of the seizures, drug of choice is valproate. But valproate, the major side effect is it can cause liver damage, and the metabolite which is producing liver damage, that metabolite will be generated more if we give it with other enzyme inducers like carbamazepine. So if we give carbamazepine plus valproate, then there is more risk of hepatotoxicity because the metabolite which is causing hepatotoxicity will be generated more. Okay? Apart from hepatotoxicity, it can cause pancreatitis. Valproate can cause pancreatitis. And third very important side effect is polycystic ovarian disease. So obviously seen in females only. So it is a gender specific adverse effects of valproate. Okay. Now there are some new drugs like retigabin. Retigabin is a drug which acts by opening the potassium channels in epilepsy, and it is metabolized by microsomal enzyme. So when we give it with the drugs like phenytoin, they will induce its metabolism. So it will require increased dose when we give with phenytoin. When we give it with phenytoin, we need to increase the dose of retigabin. Then we have drugs which act on SV2A, synaptic vesicular protein SV2A. The drugs include levetiracetam and brivaracetam. So levetiracetam, it is very less teratogenic drug. So lamotrigine and levetiracetam have least teratogenicity. So these are preferred in pregnancy. So this drug is mainly used for focal seizures. Focal seizures. First line drug in focal seizures. Then we have some new drugs, new anti-epileptic drugs like cannabidiol, stiripentol. These are the new drugs. They are used in a syndrome known as Dravet syndrome. Dravet syndrome. So these are the important points regarding the anti-epileptic drugs. Then moving to drugs for psychiatric illness. Two main types, psychosis and neurosis. Main psychotic illness in which insight is absent. It includes schizophrenia, which is the major psychotic illness, or we have affective disorder, or we can say mood disorders like mania, depression and bipolar disorder. Whereas neurotic disorders like obsessive compulsive disorder, phobia, PTSD, bulimia, these are neurotic disorders. Now starting with drugs for schizophrenia, which are called antipsychotic drugs. Psychosis occur due to excessive dopamine in the brain. So antipsychotic drug can be those which act by blocking dopamine receptors. So they are called as typical antipsychotic drug. So typical drugs are those which main mechanism is D2 blockade. Whereas drugs which have some other mechanisms, particularly the drugs which act by blocking 5-HT2 receptors, they are called as atypical antipsychotic drugs. Okay? Now typical antipsychotic drugs, these act by blocking T2 receptor. The drugs include drugs like haloperidol, flufenazine, chlorpromazine. These are D2 blockers. Now D2 blockade is required for producing the antipsychotic effect. So if a drug is stronger D2 blocker, it is more effective. But problem is excessive D2 blockade in the brain, it causes a group of symptoms known as extrapyramidal symptoms. So typical drugs have high chances of causing these side effects. And what are the important EPS? We have acute muscular dystonias. We have akathisia, drug-induced Parkinsonism. We have tardive dyskinesia. We have malignant neuroleptic syndrome. The important extrapyramidal symptoms. Dystonias are the earliest EPS to appear. Like there may be fixed gaze of a person, there may be the tongue rolling back. So there are dystonias. The drug of choice for dystonias is benhexol. Akathisia, it is the most common extrapyramidal side effect. Person constantly keep on walking from one place to another place. The drug of choice for akathisia is propranolol, a beta blocker. Drug of choice for drug-induced Parkinsonism, we already discussed, is benhexol. For tardive dyskinesia, drug of choice is valbenazine. And for malignant neuroleptic syndrome, we use the drugs like dantrolene. Tardive dyskinesia is very late to appear, and for this, benhexol like anticholinergic drugs is contraindicated. Okay, so typical drugs have this problem. Not only this problem, typical drugs have other side effects. They have many other properties, like they have anticholinergic property, alpha blocking property, they have seizure causing property. So typical drugs, they cause sedation also, antihistaminic action. So these are the extra side effects of the typical drugs. So that's why we developed atypical drugs. So atypical drugs have two major advantages. One, they have lesser risk of causing extrapyramidal symptoms, lesser chances. And second, these drugs are effective against both positive as well as negative symptoms of schizophrenia. Remember, typical drugs are mainly for positive symptoms. They are not affecting the negative symptoms or depressive symptoms in the patient with schizophrenia. So what are the atypical drugs? The main atypical drugs you can remember, the drugs whose name end with pin or the name ends with done, like clozapine, olanzapine, quetiapine, acinapine, zotapine, or done like risperidone, paliperidone, ziprasidone, lurasidone. Okay. So drugs whose name end with pin or done. Apart from these, one important drug you need to remember is aripiprazole. Aripiprazole. So all these drugs have lesser risk of causing extrapyramidal symptoms, and they are effective in both positive and negative symptoms of schizophrenia. The important questions to remember: as a group, all these atypical drugs have high risk of causing lipodystrophy syndrome. Lipodystrophy syndrome include weight gain, insulin resistance, hyperglycemia. So basically, these are metabolic symptoms. Metabolic symptoms increase risk of diabetes mellitus. So these all drugs have high risk, but aripiprazole is special in this situation because it is not a typical atypical drug. The important thing in aripiprazole is it is known as dopamine serotonin stabilizer. What it is meaning is it is a partial agonist at dopamine receptors and 5-HT2 receptors. Dopamine and 5-HT2 receptor partial agonist that will stabilize the balance of these two. So what is the advantage? It has lesser risk of causing EPS like atypical drugs, but as well as unlike atypical drug, it has lesser risk of causing weight gain also. Okay, so lesser weight gain and lesser EPS with aripiprazole. Now clozapine, it is very strong atypical drug, but the clozapine has other problems. What is the disadvantage of clozapine is clozapine, it has high risk of causing agranulocytosis. It can cause seizures. It can cause myocarditis. It causes sedation and it causes siluria. The main side effects of clozapine. But is important to remember, agranulocytosis is dose independent. That means we cannot predict or we cannot prevent by decreasing the dose. Seizures are dose dependent. Sedation is the most common side effect of clozapine. And siluria, what is important to remember, this is the only antipsychotic drug which causes siluria. In the saliva running out, whereas all other antipsychotic drugs, they cause dry mouth. It causes siluria. In fact, among all the CNS drugs, this is the only one which causes siluria. Okay. Then, special point to remember about risperidone. Risperidone has maximum D2 blocking property among all the atypical drugs. So, among atypical drugs, it has highest risk of causing extrapyramidal symptoms. Okay. Now, another important thing is all the atypical drugs, they have lesser risk of causing EPS. Typical have more. But typical drugs which were D2 blockers, they also cause hyperprolactinemia. So this side effect is also lesser with the atypical drugs. Then there are some atypical drugs which can be given by intramuscular route. So they can be given deep intramuscular route in a special technique known as Z-track technique, so that the drug do not come outside. So these drugs which can be given by Z-track technique, deep intramuscular long-acting antipsychotic drugs, these include haloperidol, flufenazine, risperidone, and paliperidone. These are given by Z-track technique by intramuscular route. Okay, the next group of psychotic disorders are disorders of mood, mania, bipolar disorder, and depression. So regarding mania and bipolar disorder, the drug of choice for mania and bipolar disorder, particularly bipolar disorder, is lithium. For acute mania, lithium is given along with antipsychotic drugs or benzodiazepines. Okay, now lithium is the most important antimanic drug. The important point you can remember from lithium as lithium, it leukocytes increase. So lithium causes leukocytosis. Unlike other drugs, most drugs which cause leukopenia, tremors, they are the important adverse effects of lithium. Hypothyroidism, lithium can cause hypothyroidism. increase urine means polyuria is an important side effect, and M for mothers means it is avoided in expectant mothers because of a side effect known as Epstein's anomaly. Now what is important is lithium is drug of choice for bipolar disorder. If a pregnant female has bipolar disorder, what to do? So we will try to avoid lithium, but the other drugs which are used in bipolar disorder, they may be even more teratogenic. So what are the other drugs used in bipolar disorder? First of all, quickly we can discuss. Apart from lithium, we can use drugs like valproate, carbamazepine, topiramate, and even antipsychotic drugs, particularly atypical antipsychotic drugs. So lithium, it is drug of choice normally, but it can cause Epstein's anomaly. All the anti-epileptic drugs are also teratogenic. So the safest drug are antipsychotic drugs in pregnancy. Drug of choice for bipolar disorder in pregnancy are antipsychotic drugs. But suppose antipsychotic drugs are not tolerable, so we have to choose among them. Still the drug of choice will be lithium. Valproate we will never choose because it is most teratogenic anti-epileptic drug. So we will not choose this, but lithium we can use, but we will try to avoid. It can cause Epstein's anomaly. Now lithium is very toxic drug. The plasma concentration of lithium should be between a narrow range. It has a narrow therapeutic index. What are those range? For acute mania, the plasma concentration should be between 0.8 to 1.2 milliequivalent per liter. For bipolar disorder or for prophylaxis of mania, it should be between 0.5 to 0.8 milliequivalent per liter. And if the plasma concentration is more than 1.5, it lead to toxicity. 1.52 level, they are indicative of toxicity. Now first of all, when to take plasma level? Half-life of lithium is 24 hours. So for taking the plasma level, we want the drug to attain a steady state first. So minimum after 5 days of starting lithium therapy, we should take the plasma level. Second thing, at what time to take plasma level? So lithium is given twice a day. So that means after 12 hours. So plasma level, what we will take, we'll ask the person to take morning dose, and after 12 hours we will take. So that means it is 12 hours after last dose. So basically we want to measure the trough level of the lithium. So that will give after the 12 hours of the first dose. Okay? So lithium plasma level, minimum 5 days person should be taking lithium, and after taking the last dose 12 hours later we will take the plasma level, and the levels we want to maintain are these. Now lithium is very toxic, so a lot of interactions are there. So lithium toxicity can be precipitated by lithium. That means the first three drugs, first three letters are important. L for lisinopril, I for indomethacin, and T for thiazides. Lisinopril, indomethacin and thiazide, they increase the tubular reabsorption of lithium from the proximal tubule. Reabsorption of lithium is increased from the proximal tubules, that can lead to toxicity. So we should be careful while giving these drugs with lithium. Second thing, there are some interactions particularly with food, like fasting. If a person keeps fasting, less intake of sodium is there, the body will retain more sodium along with lithium. So that can lead to toxicity. Fasting can precipitate toxicity. So what is seen in toxicity is, in lithium toxicity, what we will see mainly the GI symptoms and CNS symptoms. These are the warning signs. So nausea, vomiting and severe diarrhea among GI symptoms. And in CNS symptoms, like we have tinnitus, incoordination. These are the symptoms which will indicate the lithium toxicity. Okay. So lithium is very, very important drug for mania and bipolar disorder. Then the second topic in mood disorder is depression. So antidepressant drugs which we use, they mainly act by increasing serotonin. So new theory says that BDNF decreases in depression. So if we want to increase BDNF, we have to increase monoamines. So antidepressant drugs, they may be again typical or atypical. Typical are those which mainly act by increasing serotonin. And how to increase serotonin? We have typical drug of two types. One which are MAO-A inhibitor, drugs like moclobemide, they are MAO-A inhibitors. And second, we can inhibit the reuptake of serotonin. The drugs may inhibit reuptake, and the drugs which inhibit reuptake, they may be further of two types. They may be non-selective reuptake inhibitors or selective serotonin reuptake inhibitors. The non-selective reuptake inhibitors are further of two types. They may be tricyclic antidepressants or they may be serotonin noradrenaline reuptake inhibitors. Now, starting with the TCAs, tricyclic antidepressants, examples like drugs ending with pramine, imipramine, desipramine, clomipramine, or drugs ending with the triptyline like amitriptyline, nortriptyline. These are tricyclic antidepressants. What is important is they inhibit reuptake of both serotonin and noradrenaline, and that will treat the depression. But problem is these are highly toxic drugs. What is toxicity is they have high risk of causing arrhythmias. Wide QRS complex will be seen, right axis deviation may be seen in overdose. Apart from arrhythmias, these drugs have very strong alpha blocking property, anticholinergic property, antihistaminic property, and seizure causing property. So in overdose, there will be symptoms of alpha blocker, that means hypotension. There will be anticholinergic symptoms, atropine like symptoms, dry mouth, mydriasis, these will be seen. There will be sedation, person may go to coma and the person may throw seizures. So, and the dangerous most, these can cause metabolic acidosis. So in short, these are very, very toxic drugs. So if overdose of these drugs occur, mostly arrhythmias will be seen. So these arrhythmias we can manage by giving sodium bicarbonate. That is very important. It will not only treat acidosis but also treat arrhythmias. So if the question is commonly asked, TCA poisoning symptoms are given, which is the drug? Answer will be sodium bicarbonate to treat that. Okay. So TCAs are not commonly preferred. Then second group of non-selective drugs are SNRI, serotonin noradrenaline reuptake inhibitors. These drugs include venlafaxine, desvenlafaxine, milnacipran, levomilnacipran, and duloxetine. These drugs inhibit reuptake of both serotonin and noradrenaline like TCAs, but they do not contain those side effects. So they are relatively safer, rather very much safer as compared to TCAs. So these are drug of choice for severe depression. Then coming to SSRIs, selective serotonin reuptake inhibitors, drugs like fluoxetine, paroxetine, depoxetine, fluvoxamine, sertraline, citalopram, and escitalopram. These are important SSRIs, and SSRIs are very, very safe, and these are drug of choice for depression. Not only depression, they are drug of choice for almost all neurotic disorders like OCD, bulimia, phobia, PTSD. SSRIs are drug of choice for all of them. Now, SSRIs are usually very safe. Negligible side effects, the most common side effect being GI side effects like nausea, vomiting. Apart from GI side effects, SSRIs at the start of therapy increase anxiety. CNS side effects obviously will be there. At the start of therapy, they increase anxiety, but continuous use will decrease anxiety. So SSRIs are used for treatment of anxiety disorder also. So they can cause CNS side effects like insomnia. Now, the main problem with SSRIs are these sexual side effects. They can cause anorgasmia and delayed ejaculation. Anorgasmia and delayed ejaculation may be seen. Because of this side effect of delayed ejaculation, they can be used for premature ejaculation. In particular, the drug which is used for this is depoxetine. Now, all the antidepressants which we have discussed, antidepressants, if we suddenly stop, that can lead to rebound. Yeah? So that is known as a discontinuation syndrome. Discontinuation syndrome. And this discontinuation syndrome, the risk is lowest with fluoxetine because it is very, very long acting drug. And when we stop this, it acts as automatic tapering of this drug. Okay, so this is about the typical antidepressant drugs. Now moving to atypical antidepressant drugs. Atypical antidepressant drugs like tianeptine, amyneptine, bupropion, and the newer drugs like S-ketamine, vilazodone. These are the new drugs among the antidepressants. Tianeptine and amyneptine, they increase reuptake of serotonin. Still, they are used in depression because they have some other mechanism. Bupropion is an anti-smoking drug. Bupropion is anti-smoking drug. Remember, the name says PO, Sutta PO. S-ketamine is a new anti-depressant drug checked by blocking NMDA receptor, and it is given by nasal route. This is important, given by nasal route. Vilazodone is a new atypical antidepressant drug. Okay, so these are the important points regarding the drugs for psychiatric illness. Moving to the last topic in the CNS, this is about addictive drugs. And the most important addictive drugs we have is alcohol. We have tobacco, that means smoking. We have cocaine, and we have opioids. Now, alcohol. The commonly consumed alcohol is ethyl alcohol. So, ethyl alcohol is metabolized to aldehyde, which is metabolized to acid. So, in alcohol addiction, if the alcohol is a CNS depressant, so person become addicted. So, when we want to stop the addiction, what we need to do? We have to stop the withdrawal symptom first. And for stopping the withdrawal symptom, we will give benzodiazepines. Benzodiazepines, usually long-acting benzodiazepines like diazepam or chlordiazepoxide are used. These are used. But if a person is having liver disease, these are metabolized by liver. So if there is liver disease, then the benzodiazepine for alcohol withdrawal we use is lorazepam. Lorazepam is used in liver disease. Okay. Now, apart from using drug for withdrawal symptoms, we want to decrease craving. So certain drugs can decrease craving of alcohol. And what are those drugs? Drugs which decrease the craving, you can remember that none of the above. The drugs which decrease craving are naltrexone, ondansetron, topiramate, and acamprosate. These will decrease craving of the alcohol. Then we have a drug called as disulfiram. Disulfiram, it inhibits aldehyde dehydrogenase enzyme. Aldehyde will accumulate and that will cause adverse symptoms. So whenever the person drink alcohol, there will be lot of symptoms. So person will quit alcohol. So this is known as alcohol aversion therapy. Alcohol aversion therapy. Now there are many more drugs which inhibit aldehyde dehydrogenase but are not used in alcoholism. So if a person is occasional drinker and take those alcohol along with those drugs, then same symptom will occur. So that is known as disulfiram-like reaction. So the important drugs which cause disulfiram-like reaction, you can remember from cyclic GMP. These include chlorpropamide and cefoperazone, griseofulvin, metronidazole, and procarbazine. Important drugs causing disulfiram-like reaction. Okay. Then along with the toxicity of alcohol, sometimes there is methyl alcohol poisoning, methanol poisoning, or methyl alcohol poisoning. The drug of choice for methanol poisoning is alcohol dehydrogenase inhibitor, which is called as fomepizole. Fomepizole, or full name is 4-methylpyrazole. This is drug of choice for, or we can say antidote of choice for, methanol poisoning. It is also used for ethylene glycol poisoning. Okay, so that is about the alcohols. Now, second of the addictive drug is tobacco, smoking. So anti-smoking drugs. The important anti-smoking drugs, one is nicotine replacement therapy known as NRT. Second is varenicline, and third is bupropion. Now, what is important about these to remember, nicotine replacement therapy is usually the earliest one to be used, because the patient usually, the smoker usually can go to the pharmacist shop and take these drugs. So what is in them is they are available in the form of chewing gums or lozenges or the nasal spray. Also in many forms they come. So they will basically, when the person is not smoking, person is not getting nicotine, so withdrawal symptom come, so they will decrease the withdrawal symptoms. So the person is getting nicotine instead of taking the nicotine from the smoking, the person is taking from these chewing gums, etc. Now these drugs, they are taken by the GIT route, they are absorbed, and that will give these high, or we can say stimulate the brain, so prevent the withdrawal symptoms. Now second is varenicline. It is the most effective therapy, most effective single therapy. If we use single therapy, most effective single therapy is varenicline. It is nicotine receptor agonist, you can say. And bupropion we discussed. Bupropion, it is an antidepressant drug also, and it is used in smoking. Okay? Then third is cocaine. You know, cocaine is a local anesthetic also, name ending with K. Among all the local anesthetics, this is the only one which cause vasoconstriction, others cause vasodilation. So if there is cocaine addiction, in overdose there will be symptoms of vasoconstriction. Vasoconstriction can lead to hypertension. The cocaine inhibits the reuptake of noradrenaline also, so that can cause sympathetic excess symptoms like tachycardia, palpitation, tremors. All these symptoms can come. Apart from these, cocaine causes cocaine bugs, tactile hallucinations. So the person with cocaine addiction, the person is scratching on the skin, so there will be scratch marks. There may be a lot of scratch marks, which from there the skin may be denuded also. There will be oozing of the skin also. So lot of scratch marks will be seen. So if a person is presenting with some addictive drug addiction, person is having cocaine bug symptom, that is scratching of the skin, person is having sympathetic excess, tachycardia, palpitation, etc., it is cocaine addiction. Okay. Then moving to the last but the most important, opioid poisoning or opioid addiction. Now opioids are the drugs like morphine. So they act on three receptors, mu, kappa and delta. And important actions of opioids you can remember from the mnemonic sacrum. So these include sedation, analgesia, constipation, respiratory depression, euphoria and meiosis. Opioid like morphine, they cause sedation. In overdose, person can go to coma. They produce analgesia, so they are used for pain, severe pain. Most of the pains we can use opioid like morphine, but they are contraindicated in biliary colic because they can cause spasm of sphincter of Oddi. Then opioids can cause constipation. So some opioids like loperamide are used to treat diarrhea. They can cause respiratory depression, so they are avoided in conditions like COPD and asthma, respiratory diseases. They cause euphoria, so they are addictive. Opioids are addictive, and addictive drugs can produce withdrawal symptom if we suddenly stop, and withdrawal symptom will be opposite to the normal action. So opposite to this will be withdrawal of opioids. So sedation, opposite is seizures, stimulation of brain. Analgesia, there will be diffuse body pain. Constipation, opposite is diarrhea. Respiratory depression, opposite is tachypnea. This meiosis, opposite is mydriasis. These are symptoms of opioid withdrawal symptoms. Then meiosis, in overdose, opioid can cause pinpoint pupil, important sign of opioid poisoning. Now if kappa is stimulated more than mu receptors, it causes dysphoria, which can manifest as hallucinations. Okay. Now coming to important opioids, the most important being morphine. Apart from morphine, we have drugs like codeine, codeine. These drugs are used as antitussives. These are opioids, they are used as antitussive. They will be used for dry cough. Apart from that, we have drugs like loperamide and diphenoxylate. These are used as drugs for treatment of diarrhea, but very important is they are used only for non-infective diarrhea. They are contraindicated if diarrhea is due to infection. They are used to treat non-infective diarrhea. Then we have drug called as tramadol, and similar drug is tapentadol. These drugs, apart from stimulating the mu kappa delta, which is done by all, these drugs have additional action on inhibiting the reuptake of noradrenaline and serotonin. So that means they have additional action apart from the opioid action. So their analgesic mechanism have two parts: one opioid like, and second additional action of inhibiting reuptake of noradrenaline and serotonin. Then we have a drug called pethidine. Pethidine is mostly metabolized by monoamine oxidase enzyme and become inactive, but little bit of pethidine can form norpethidine, and this can stimulate the brain, which can lead to seizures. So if we give pethidine for long periods, it can cause seizures because of stimulation of brain. And if we give pethidine with MAO inhibitors, even a single dose can cause seizures. So that is the important problem with the pethidine. Then we have a very long acting drug called methadone, which is used mainly for opioid de-addiction. It will gradually decrease the symptoms, so used for opioid de-addiction. Then apart from these agonists, we have drugs called as partial agonist. We have a partial agonist at a mu receptor, which is called as buprenorphine. This drug, it has a ceiling effect on respiratory depression. Then we have drug which is called as agonist antagonist. Agonist antagonist means it is agonist on kappa and antagonist on mu receptor. This drug is pentagocin. So this is a drug which can cause a dysphoria as a side effect, hallucinations as a side effect. Then we have drug which are opioid antagonist, and two main antagonists we have. One is naloxone and second is naltrexone. Both are antagonists of mu kappa delta, all the receptors, but what is important, naloxone is short acting, naltrexone is long acting. Naltrexone is given orally, whereas naloxone is given IV. Okay? Naloxone is a drug of choice for acute opioid poisoning. Drug of choice is naloxone, whereas naltrexone is used for maintenance in case of opioid poisoning. It can be given orally and it is long acting. Naltrexone is also used to decrease relapse in opioid addiction. Is naltrexone. Okay? So these are the important points regarding the drugs used in CNS. Okay. Our next topic is anesthesia, the drugs used in anesthesia. And we divide these into broadly three parts: local anesthetics, skeletal muscle relaxants, and general anesthetics. So we'll discuss one by one quickly, starting with the local anesthetics. So local anesthetic, we all know these act by blocking the sodium channels in the neurons. So sodium cannot enter, depolarization cannot happen. But important thing to remember is these mainly act in the open state. When the sodium channels are open, then the local anesthetic act more effectively. That's why they are more effective in rapidly firing neurons. Second thing, almost all the local anesthetics are basic in nature. So if we add sodium bicarbonate in basic medium, the drug will become non-ionized, so they can quickly cross the axonal membrane, so they will work faster acting. So sodium bicarbonate is added to local anesthetic to make them faster acting. Okay. Now there are two main type of local anesthetics. One are esters, second are amide. All the local anesthetic, the names will end with cane. Ester as well as amide, the name end with cane. The examples of ester local anesthetic include cocaine, procaine, chlorprocaine, tetracaine, benzocaine. Whereas examples of amides include lignocaine, also known as lidocaine, bupivacaine, prilocaine, atidocaine, dibucaine. Now you can easily remember them. The ester local anesthetics, they contain one I in the name only, that of cane. Whereas amide local anesthetic, apart from I of cane, they contain one more I. So that means if we remove the cane and see the name, if I is present, it is amide because amide contains I. If I is absent, it is ester. So why we divide based on the chemical structure is, if a person is allergic to one group of drugs, like person is allergic to cocaine, then we should not give any other ester local anesthetic, then we should give amide local anesthetic. Okay. Now important point regarding individual drugs, all local anesthetic, they are vasodilators, so they can lead to hypotension. Only exception is cocaine, because the name of the cocaine itself says it causes constriction. Cocaine inhibits the reuptake of noradrenaline, so it is a sympathetic drug, it can cause vasoconstriction. So cocaine is the only local anesthetic which can increase the BP, all other will decrease. Then chlorprocaine is shortest acting, whereas dibucaine is longest acting local anesthetic. Bupivacaine is most cardiotoxic local anesthetic. Prilocaine can cause methemoglobinemia, and lignocaine is the most commonly used local anesthetic. Now, apart from this, second important thing to know about local anesthetics is, when we give local anesthetic for infiltration anesthesia, suppose we want to suture the injury. So this is the part where we want to suture the injury. We inject the local anesthetic all around this area. Now the blood vessels which are present here, local anesthetic may enter that. Due to that, local anesthetic will go away. So this will have two implications. One, local anesthetic has gone away, so it becomes short acting. And second, it will go to heart and brain or other organs of the body, that will lead to toxicity, systemic toxicity. And both of these problems we can sort out if we add adrenaline, which cause vasoconstriction. So along with the local anesthetic, we add adrenaline. It serves two functions. One, it make the local anesthetic long acting, and second, it will decrease the systemic toxicity. And the concentration of adrenaline used is usually 1:1 lakh to 1:2 lakh. Okay. Now, if local anesthetic enter the systemic circulation, they can affect the heart and brain. They can cause cardiotoxicity, they can cause neurotoxicity. So if we give local anesthetic by mistake intravenously, or high amount of local anesthetic is given, that can lead to local anesthetic toxicity, which can manifest as tachycardia, hypotension, arrhythmias, and cardiovascular collapse. So if these features are present, the treatment of choice obviously is cardiopulmonary resuscitation. Along with that, we have to give 20% intralipid. So that is the treatment of choice for local anesthetic toxicity. Okay. Moving to second group of drugs, these are skeletal muscle relaxants. If you see, this is the skeletal muscle. It is supplied by the CNS, brain and spinal cord. So this junction is called as neuromuscular junction. So muscle relaxants, they can be broadly of two types. One which stop this, that means they will act on the CNS, they are called as centrally acting muscle relaxant. Second, which act on the muscle itself, which are called as peripherally acting muscle relaxant. Now centrally acting muscle relaxant, we can broadly divide. They can either act by stimulating GABA, because GABA is inhibitory amino acid, or they can act by stimulating alpha-2, which act like a brake. So two type of drugs, one which stimulate GABA A receptor finally, indirectly, that is benzodiazepines like diazepam, and second which can stimulate GABA B receptor, which is baclofen. Whereas alpha-2 agonist drug is similar to clonidine, the name is tizanidine. So these are centrally acting muscle relaxant, whereas peripherally acting muscle relaxant, they may further be of two types. One which directly act on the muscle, so they are called as directly acting, and second which act at neuromuscular junction, so they are called as neuromuscular blocker. And directly acting muscle relaxant, you can remember D for directly acting, D for dantrolene. It is directly acting muscle relaxant. It is a drug of choice for malignant hyperthermia and neuroleptic malignant syndrome. But the main side effect is it can cause hepatotoxicity. Whereas neuromuscular blockers, they act by working on NM receptors on the muscle endplate. Now they can be of two types. One are called as depolarizing neuromuscular blockers, and second are called as competitive or non-depolarizing neuromuscular blockers. So NM receptor is overstimulated by a drug called as succinylcholine. So it is a depolarizing muscle relaxant. The special point about succinylcholine is S for shortest acting. It is very short acting, action lasts for less than 5 minutes. The reason is it is metabolized by pseudocholine esterase. And if a person has atypical pseudocholine esterase, it will not be metabolized that quickly. That can lead to apnea. Okay. Then C for contraindicated. It is contraindicated in patient with nerve and muscle injuries because it can lead to severe hyperkalemia in these patients. So nerve and muscle injuries can lead to hyperkalemia. Third, H for hyperthermia. That means it can cause malignant hyperthermia as a side effect. Malignant hyperthermia basically occurs because of mutation in calcium channels. So ryanodine receptors which are mediating the entry of calcium, there is mutation in that lead to malignant hyperthermia. Okay, so that is special about succinylcholine. Then coming to competitive, succinylcholine has one problem that it can cause pain because it stimulates the NM receptor. So we will try to block the NM receptor, and the drug which block, or we can say non-depolarizing muscle relaxant, the first drug formed was D-tubocorarine. But that has a big disadvantage that it causes release of histamine. So plenty of histamine is released, which can cause vasodilation, which can cause bronchoconstriction. So that can lead to adverse effects. So because of that, we developed the newer non-depolarizing muscle relaxants, which do not release histamine, or rather less histamine. So we developed two type of drugs, one whose name end with curium, and second whose name end with coroniums. So curiums like atracurium, cis-atracurium, mivacurium, whereas coroniums like pancuronium, vicuronium, rocuronium, rapacuronium, the drugs ending with coronium. So now the basic difference between curium and coronium is curium release less histamine than tubocorarine, whereas coronium release no histamine at all. So you can see the name of both contains CUR-IgM, but it contains NO, no. So no histamine at all. So coroniums are drug of choice if a patient is having bronchial asthma, because in such a patient we require no histamine. It causes bronchoconstriction. On the other hand, curiums, you can remember atracurium and cis-atracurium both are degraded by Hoffman's elimination. Hoffman's elimination is spontaneous degradation without requiring any liver or kidney. So these are preferred in a patient with liver as well as kidney disease. If a person has both of them, we prefer atracurium or cis-atracurium. The difference between them, cis-atracurium releases lesser histamine than atracurium. Otherwise, they are similar drug. Cis-atracurium releases lesser histamine, and mivacurium is shortest acting drug among the non-depolarizing muscle relaxants. Now, these non-depolarizing muscle relaxants are usually very long acting. So we need to reverse their action. They are known as reversal agents. And two type of drugs we can use. Either we can use neostigmine or we can use sugammadex. Neostigmine, it is a cholinergic drug. It inhibits acetylcholine esterase that will increase acetylcholine. So by increasing acetylcholine, it will stimulate NM receptor and reverse the action, but it can produce muscarinic side effects can be there because it stimulates M1, M2, M3 also. So to stop them, we add atropine. So neostigmine is commonly given with atropine. On the other hand, sugammadex is relatively faster acting than neostigmine like drugs, and it directly work on the directly bind to the neuromuscular blockers. So it is also known as selective relaxal binding agent, and they do not cause cholinergic side effects. Okay, so that is about the muscle relaxants. Then moving to general anesthetics. General anesthetics may be intravenous, which are known as inducing agents, and they may be inhalational, which is known as maintenance agents. The important inducing agents include ketamine, propofol, etomidate, and thiopentone. So first quickly finishing about these, starting with ketamine. So important point about ketamine, you can remember from ketamine itself. K for kids, it is intravenous anesthetic agent of choice in children. E for emergence reaction. When we give ketamine, nothing happens, but when the person is recovering or emerging from anesthesia, that lead to CNS side effects like hallucinations. T for thalamocortical junction. It is the site of action. Due to this site of action, it can lead to dissociative anesthesia. Very important MCQ which is asked. Which drug causes dissociative anesthesia? It is ketamine. Then A for analgesia. Among the anesthetic agent, it is the most powerful analgesic drug. M for meals, means it can be given in full stomach. I for increase, it increase blood pressure, intraocular pressure as well as intracranial pressure. Because it increases BP, it is anesthetic agent of choice in patient with shock. It increases intraocular pressure, so avoided in glaucoma. It increases intracranial pressure, avoided in head injuries. Okay. Then N for NMDA blocker. It is the mechanism, block NMDA receptor of glutamate. And E for excellent bronchodilator. So it is preferred in asthmatic patients. Okay. So that is about the first anesthetic agent, ketamine. Then propofol, the special point to remember, injection of propofol is P for painful, very painful injection is there. Remember, ketamine injection is not painful, rather it is analgesic drug. Then second thing, propofol is most commonly used drug for day care surgery. The other drugs which are used in day care surgery, you can remember as Dr. Manmohan Singh is a prime minister. Dr. Manmohan Singh is a prime minister. D for desflurane. M for midazolam. S for sevoflurane. IS for isoflurane. A for L-fentanyl. PR for propofol, we are just discussing. And MI for mivacurium. These are the drugs used in day care surgery. Propofol is most commonly used drug for that. Then etomidate, two special points to remember. Etomidate is a drug which can cause adrenal suppression. Adrenal suppression is the major side effect. But it is very safe for cardiovascular patient. It do not affect the heart, it do not depress the heart. So it is preferred in cardiovascular surgeries. Then thiopentone is a barbiturate. It is a highly water soluble barbiturate and it is very short acting. The question asked is why it is so short acting. The reason is redistribution. It is very short acting because of redistribution. Okay. So that are the inducing agents. Now coming to inhalational agents or maintenance agents. So previously we were using inhalational agents like ether, cyclopropane, chloroform, trilene, etc. But all of these were inflammable, so we cannot do cautery with them. So all the modern inhalational anesthetic agents, they are non-inflammable. And the examples of them, first drug which we formed was halothane. After that we developed many fluorines like N-fluorane, isoflurane, sevoflurane, desflurane, methoxyflurane. And very latest is a drug called as Xeno. The special point about these inhalational anesthetic agents to remember, halothane, two special points to remember. One, it sensitizes the heart to arrhythmogenic action of adrenaline, means same dose of adrenaline can cause arrhythmias. So it is avoided when there is high levels of catecholamines, like in a patient of pheochromocytoma. It is contraindicated. Second, halothane can precipitate malignant hyperthermia, like succinylcholine. Okay. Then N-fluorane, it can cause seizures as an adverse effect. You can remember E for epileptic seizures. Isoflurane is safe in cardiovascular and neurosurgeries. So it is quite commonly used for them. Sevoflurane has very smooth induction, so it is a preferred drug in children. Least irritant to respiratory pathway. Desflurane is most irritant to respiratory pathway. Most irritant to respiratory pathway is desflurane. Methoxyflurane has least MAC, that means most potent drug. Second, methoxyflurane, it releases lot of fluoride which can lead to nephrotoxicity. And third, methoxyflurane, it has highest blood gas partition coefficient, means it is the slowest acting anesthetic agent. That's why it is not commonly preferred. Now, Regarding the potency of inhalational anesthetic agents, commonly the question is asked about sequence, which is most potent, which is least potent. So you can remember the sequence of this as Mahinder Singh Dhoni. From the most potent to least potent, Mahinder Singh Dhoni. So how to remember? It is methoxyfluorine, which is most potent, halothane, then isoflurane, sevoflurane, desflurane, and nitrous oxide, which is least potent. Nitrous oxide is not a complete inhalational anesthetic agent because its MAC is 104%. We cannot cause anesthesia by giving only nitrous oxide. We have to add some supplemental gas. Okay. Then coming to xenon. Xenon is considered as an ideal anesthetic agent. It has negligible side effects. Important thing, xenon, apart from anesthetic agent, it is a powerful muscle relaxant as well as analgesic drug. Then xenon, it is having very low blood gas partition coefficient. That means it is faster acting. In fact, it is very, very fast acting. Then another important advantage is it has no side effect on the liver, kidney, heart, and any other organ, you can say. So because of all these advantages, it is considered as ideal anesthetic agent, but problem is it is very, very costly. Very costly. The last thing in anesthesia you need to remember is color coding of cylinder. So you can remember the important colors of nitrous oxide, cyclopropane, oxygen, and Antonox. So nitrous oxide, you can remember N for Neela. So nitrous oxide cylinder is blue. Cyclopropane, C for Santari, that means it is orange. ऑक्सीजन पुराने जमाने की बात है, बचपन से सांस ले रहे हैं. पुराने जमाने में क्या होता था? ब्लैक एंड व्हाइट. सो होल सिलेंडर इज ब्लैक एक्सेप्ट द शोल्डर विच इज व्हाइट. नाउ एंटोनॉक्स इज अ मिक्सचर ऑफ नाइट्रस ऑक्साइड एंड ऑक्सीजन, 50-50% mixture. So the color should also be mixture. So the color is blue and white. Whole cylinder is blue and the shoulder is white. Okay. Our next topic is hematology. So in the blood, we have two type of problems. One, the problems related to flow of blood. Second, problems related to cells of blood. Now quickly discussing how the blood flows. So this is the blood vessel. The blood is flowing through this vessel. So if the injury occurs, the blood comes out, bleeding occurs. To stop this bleeding, first of all, the platelets, they accumulate at the site of injury. And over these platelets, fibrin deposit, which will make the thrombus strong. So if there is thrombus unnecessarily, we will want that this does not happen. So the diseases like thrombotic disorders like myocardial infarction, deep vein thrombosis, we want to stop that. So for stopping that, what we need to do is we can give anti-platelet drug which prevent platelet aggregation, and anti-fibrin drug which are called as anticoagulants. Okay. Now the basic difference between arterial and venous thrombosis: in arterial thrombosis, platelets are more, fibrin is less. That's why antiplatelet are more effective. Whereas in venous thrombosis, platelets are less, fibrin is more. So anticoagulants are more effective. Yeah? So we'll talk about these two drugs first, antiplatelet drugs. For knowing these, we'll discuss how the platelets aggregate. In the flowing blood, the platelets which are present, normally they contain a receptor over their surface which is called as glycoprotein 2b/3a. The receptor name is glycoprotein 2b/3a. So whenever injury occurs to the endothelium, that lead to release of substances like thromboxane A2 and ADP. These result in exposure of this receptor. Normally this was present inside. So activation of platelet occur means this receptor become exposed. Now the platelet can aggregate. Yeah? So we have three type of antiplatelet drugs which can work. One which inhibit thromboxane A2, second which inhibit ADP, and third which inhibit 2b/3a. So the drug which inhibit thromboxane A2 formation is aspirin. Aspirin inhibit the enzyme cyclooxygenase irreversibly, that will decrease formation of thromboxane A2. Second, the drug which inhibit ADP, these include clopidogrel and ticlopidine. Ticlopidine is not used now because it causes T4 thrombocytopenia. Then we have drug which inhibit GP2b/3a The drug inhibiting are abciximab, tirofiban, and eptifibatide. So what you can remember from the names is, if you see A for aspirin, it inhibits thromboxane A2. ADP contains D, so the drug which contain D in the name inhibit ADP, and drug which inhibit 2B3A, their name contain B and A together. Okay. Now important to remember, the drug which inhibit ADP, if we go into little detail, there is a receptor of ADP on the platelets known as P2Y12. So the drug will block this receptor. They are antagonist of this. They may be of two type, irreversible and reversible. The irreversible P2Y12 antagonists, these include clopidogrel, ticlopidine, which we discussed earlier. Ticlopidine is not used now, and a new drug in this group is prasugrel. Now special MCQ to remember, clopidogrel is a prodrug. It is activated by an enzyme known as CYP2C19. So if there is genetic deficiency of this enzyme, it will not become active. So when it do not become active, it will lead to thrombosis because it is not working. So the people who have less working of 2C19 can lead to more attacks of stroke and other thrombotic disorders. Second thing, because clopidogrel do not work. Second thing, enzyme inhibitors like omeprazole, if given along with clopidogrel, it will inhibit the activation of clopidogrel, so it will not work. Okay. Prasugrel, it is faster acting than clopidogrel, but it is contraindicated in stroke because it increases the risk of cerebral hemorrhage. Okay. Then coming to reversible drugs include drugs like ticagrelor and cangrelor. So like clopidogrel, prasugrel, they have grel in the name and R at the end, say they are reversible P2Y12 antagonist. Okay. So that is about antiplatelet drugs. Now coming to second group, which are anticoagulants. Now anticoagulant drugs, they may be divided based on the route of administration into oral anticoagulant and injectable anticoagulants. Oral anticoagulants, it include vitamin K antagonist like warfarin. Then we have new oral anticoagulants, which are known as new oral anticoagulants. Two main groups are there. One is direct thrombin inhibitor, example is dabigatran. And second is factor 10A inhibitors, the drugs whose name end with hexaban. Hexaban says 10A blockers like rivaroxaban, apixaban, edoxaban, betrixaban. So any drug ending with hexaban is direct oral anticoagulant which inhibit 10A. Okay. Now dabigatran, we have an antidote for dabigatran which is known as idarucizumab. So in case of toxicity of dabigatran, we can give idarucizumab, whereas in case of toxicity of hexabans, we can give a drug known as andixanet alpha. So andixanet alpha, the name says it is antidote of 10A neutralizers. Okay. Now coming to the most important drug, warfarin. So before that warfarin, quickly we can discuss the injectable drugs also. Injectable drugs, they may be indirect thrombin inhibitors. Indirect thrombin inhibitors, examples are heparin group of drugs. And we have direct thrombin inhibitors. Direct thrombin inhibitors, examples like hirudin like drugs, the drugs whose name end with rudin, hirudin, vivalirudin. Then we have drugs like argatroban, malagatran, etc. The drugs whose name end with the tran, thrombin antagonist or thrombin antagonist. Okay. Now we will discuss in detail about warfarin and heparin. So starting with the warfarin, we will compare it with the heparin also. Warfarin is given orally, whereas heparin is given by injection, either IV or subcutaneous. Then warfarin act by inhibiting vitamin K antagonist, whereas heparins, they activate antithrombin. When antithrombin is activated, it can inhibit factor 2A and factor 10A. The unfractionated heparin, it inhibits both 2A and 10A equally. Low molecular weight heparins, they inhibit 10A more than factor 2A, and fondaparinux, it inhibit only 10A. It do not inhibit 2A. But all of these work by activating antithrombin. Okay? So that is the mechanism. Then onset of action. Warfarin action is very slow. Warfarin action takes 4 to 5 days. So it is used mainly for maintenance purpose. Whereas heparin's actions are faster. So it is used for acute cases. Then warfarin, if we give early on, it can lead to thrombosis by inhibiting protein C activation, and that early onset thrombosis can lead to dermal vascular necrosis. Dermal vascular necrosis, also known as purple toe syndrome. It is an early appearing side effect of warfarin, whereas this side effect do not appear in heparin. Then warfarin is avoided in pregnancy. So particularly in first trimester, if we give warfarin, it can lead to fetal warfarin syndrome. So we should replace it with heparins. Whereas heparins do not cross the placenta, they are safe in pregnancy. Then monitoring of warfarin is done by prothrombin time or INR, whereas monitoring of warfarin is done by APTT. Then warfarin antidote is vitamin K, whereas heparin antidote is protam sulfate. But another important thing to remember, warfarin toxicity can be treated according to the level of INR. So if the INR value is less than 5, then nothing to be done, only stop warfarin. If it is between 5 to 20, then we need to stop warfarin and start vitamin K. But if it is more than 20, then we will give directly the activated factors. 2, 7, 9 and 10. A. All are activated. Activated factors. This is known as 4-factor complex or prothrombin factor complex. Prothrombin factor complex. If this is not available, we can give fresh frozen plasma. If that is also not available, we can give whole blood also. Okay? So that is warfarin overdose. And if there is bleeding which has already started, then irrespective of value of INR, directly we will treat with 4-factor complex. Okay. Then lastly, warfarin, it is metabolized by microsomal enzyme. So if we give enzyme inducer or inhibitor, they may affect the level of warfarin. Warfarin become ineffective with inducer, like rifampicin, it will become ineffective, and enzyme inhibitors may increase its effect, which can lead to bleeding. Okay. Whereas in heparin, these interactions do not happen. Okay. Now lastly, there is a new antidote known as siraparantag. Siraparantag, this has not been approved till now, but it is a non-specific antidote for most anticoagulants. That means it is antidote for direct thrombin inhibitors like dabigatran. It is antidote for factor 10A inhibitors like exabans, rivaroxaban, apixaban, edoxaban. It is antidote for heparins also. Heparins including unfractionated heparin, low molecular weight heparin, as well as fondaparinux. So it is a non-specific antidote for most of the anticoagulants. Okay. Then third group of drug which affect the blood flow is known as thrombolytic. Another name is fibrinolytic. The drugs are nothing but tissue plasminogen activators. They will activate plasminogen which is present to plasmin. Okay. And the main TPA we are using is streptokinase, urokinase, LTplase, retiplase and tenecteplase. These are fibrinolytic drugs. They will break the thrombus, so they are used in acute conditions like acute MI, acute stroke, etc. If overdose occur, we can give antidote. The antidote is known as antifibrinolytic. And the antifibrinolytic drug include tranexamic acid, and EACA, which is epsilon aminocaproic acid. Okay. So these are the drugs affecting the blood flow. Now the drugs affecting the blood cells, these include hematinics and growth factors. Hematinics are the nutritional factors which help in formation of blood, and the most important among them will be iron, folic acid and vitamin B12. Folic acid and vitamin B12 are used to treat megaloblastic anemia, whereas iron is used for iron deficiency anemia, which is a microcytic hypochromic anemia. And in iron deficiency anemia, when we give iron therapy, the most important thing is some factor which can increase the absorption and some factor which can decrease the absorption. Particularly, it is given with citrus fruits which contain vitamin C like ascorbic acid. It increase the absorption, and reducing agents like hydrochloric acid also increase the absorption. Whereas absorption is decreased by the substances like phytate, oxalates, etc. So tea, coffee, tannate, they can decrease the absorption of iron. Okay. Then coming to growth factors. So growth factors, we have growth factor for RBC, WBC as well as platelets. The growth factor for RBC is called as erythropoietin. So it will be used for anemia, particularly anemia due to chronic renal failure or anemia due to bone marrow suppression like anti-cancer drugs. Then we have growth factor for WBCs. These include filgrastim, molgrastim and sargramostim. So grastims are granulocyte stimulator, that means GCSF, whereas gramostim are GMCSF. So these are used to treat neutropenia due to anti-cancer drugs. Then the drug which is platelet growth factor is interleukin 11 endogenous, and the drug is oprelvecin. Oprelvecin is recombinant interleukin 11. The name says it is kin means interleukin and 11 means interleukin 11. Okay. Now oprelvecin is used for thrombocytopenia due to anti-cancer drugs. Then lastly, we have another growth factor for platelets which is known as L-thrombopag. So L-thrombopag is nothing, it is thrombopoietin receptor agonist. It can be given orally and it is used mainly for treatment of idiopathic thrombocytopenic purpura. Okay. So these are the important drugs used in hematology. Next topic is respiratory system. In respiratory system, most important topic is bronchial asthma. So quickly discussing, this is mast cell. This is on first exposure IgE antibodies comes and attaches. Now if the antigen comes again, it will bind to IgE, antigen antibody reaction occur, mast cell will break and the leukotrienes which are present in the mast cell will be liberated and they will cause bronchoconstriction. That is the problem in asthma. So the drugs which we can use in asthma, they are bronchodilators. They can decrease leukotrienes, they can stabilize the mast cell and they can stop antigen antibody reaction. So 4 type of drugs, starting with the bronchodilators. We have 3 group of bronchodilators. One are beta 2 agonists. Second are anticholinergics or M3 blockers, and third is phosphodiesterase inhibitors or theophylline like drugs. Starting with beta 2 agonist, we have short acting beta 2 agonist drugs like salbutamol and terbutaline. Then we have long acting beta 2 agonist like salmeterol and formoterol. So the drugs which contain metro in the name, metro lamba chalti hai to wo long acting. Now salbutamol, terbutaline are short acting. They are used for acute attack of asthma. Whereas long acting drugs both can be used in prophylaxis of asthma. However, formoterol is fast acting also, so it can be used for acute attack also. That means formoterol can be used in acute attack as well as prophylaxis, whereas salmeterol is slow acting, so it cannot be used for acute attack. That means salmeterol is only for prophylaxis of asthma. The main side effect of beta 2 agonists are 4 T's. These are tremors, tachycardia, tolerance, and T wave changes in ECG due to hypokalemia. Okay, tremors are the most common side effect of beta 2 agonists. Then according to latest guidelines, GINA guidelines, the drug of choice for asthmatic attack to prevent the attacks as well as to treat the acute attack is salmeterol plus inhaled corticosteroids. Okay, so that is about the beta 2 agonist. Then coming to M3 blockers, anticholinergic drugs, second group of bronchodilators. The examples are ipratropium and tiotropium. So they can be given by inhalational route again. Now what is important is some people, they develop paradoxical bronchoconstriction with ipratropium. Paradoxical bronchoconstriction with ipratropium. The reason why they may develop bronchoconstriction with ipratropium is there may be impurities in the ipratropium like benzalkonium or EDT. Second, in the nebulizers, if we use hypertonic saline, it may irritate the respiratory pathway that can result in bronchoconstriction. And third, they may presynaptically block the muscarinic receptor, and that will lead to release of acetylcholine, which can cause bronchoconstriction. Okay, but this is quite rare. Then third group of bronchodilator is phosphodiesterase inhibitors, particularly drugs like theophylline or aminophylline. Now what is important is these drugs are not effective by inhalational routes, so they are given either orally or intravenously. Now these drugs not only inhibit phosphodiesterase, which is their main mechanism, but they are also adenosine A1 receptor antagonists. So these receptors are producing beneficial bronchodilatory effect, but they can also lead to side effects. The phosphodiesterase inhibition can lead to arrhythmias and GI side effects like nausea, vomiting. Whereas adenosine receptor antagonism can result in side effects like A for arrhythmia. That means arrhythmia can be caused by A1 blockade as well as phosphodiesterase inhibition. Then D for diuresis and E for epileptic seizures or simply seizures. So these side effects are due to adenosine antagonism. Now theophylline, it is metabolized by microsomal enzymes. So enzyme inducers like rifampicin, smoking, that may decrease its efficacy. We need to increase the dose. Whereas enzyme inhibitors like ciprofloxacin, erythromycin, they can inhibit the metabolism that can lead to toxicity. And at the toxic doses, they stimulate the heart and brain. So that can lead to tachycardia, palpitation, and seizures, etc. as the side effects. Okay. So these are important points regarding the first group of anti-asthma drugs, which are bronchodilators. Then second, we can decrease leukotrienes. So how leukotrienes are produced is important. Phospholipids in the membrane, they produce arachidonic acid with the help of enzyme phospholipase A2. This arachidonic acid may be converted to prostaglandin by COX and leukotriene by LOX. Now the leukotrienes, they work on their receptors, leukotriene receptor, which cause bronchoconstriction. So to decrease the action of leukotrienes, we have options. We can inhibit phospholipase A2, we can inhibit LOX, and we can block receptors. The drug inhibiting phospholipase A2 are steroids. Now important thing is steroids are not bronchodilators, but we can use steroids in the acute attack of asthma because of their anti-inflammatory effect, as well as because they increase the sensitivity of bronchus to beta 2 receptors. So beta 2 receptors, they become more sensitive, so salbutamol like drug can work better. Second, the drug inhibiting LOX is xylutone, and drug inhibiting leukotriene receptors are zafirleucast and monteleucast. So these are leukotriene receptor antagonists. The name says leucast is leukotriene antagonist, whereas xylutone says inhibit leukotriene number, means inhibit the engine. Then third group of drugs in bronchial asthma, they are mast cell stabilizers like nidochromin and ketotifen. These are used only for prophylaxis of asthma, cannot be used in acute attack because they are inhibiting the breakdown of mast cell, and they are not effective when mast cell is already broken. And lastly, the drug which is against IgE, we have antibody against IgE, and the name of that drug is omalizumab. It is given subcutaneously. When asthmatic attack cannot be prevented by other drugs, we will add this drug. Okay, so these are the important points regarding the respiratory system. Our next topic is GIT. In the GIT, the most important disease to discuss is peptic ulcer disease. We know peptic ulcer disease occurs due to more acid in the stomach. So most important drugs for peptic ulcer, these are drugs which can decrease the acid production. And we know how acid is produced. This is the parietal cell. It contains proton pump or hydrogen potassium pump, which secrete the proton and in exchange with potassium. Now this pump is stimulated by histamine, acetylcholine and gastrin, but it is inhibited by prostaglandins, particularly prostaglandin E2. So if we want to decrease acid, the option we have are we can stop histamine action, stop acetylcholine action, and increase prostaglandin action and block proton pump itself. So 4 type of drugs we can use. One, the drug which can block histamine receptor, which is mainly H2 in the stomach. The drugs like ranitidine. So drugs ending with the tidine, ranitidine, cimetidine, loxatidine, famotidine, etc. Nizatidine. Then second, we can give a drug which is M1 blocker. M1 receptor is present in the stomach. The drugs like pyrangiapine and talanzapine. And third, we can give prostaglandins. Prostaglandin E1, which work like E2. The drug is misoprostol. What is important to remember, misoprostol is most specific drug for NSAID induced peptic ulcer, because NSAIDs work by decreasing prostaglandins, whereas it is not the drug of choice. This is important to remember. It is not the drug of choice for any type of peptic ulcer. Drug of choice for almost every peptic ulcer is proton pump inhibitor, even for NSAID induced peptic ulcer. Then lastly, we can give a drug which are proton pump inhibitors. Drug inhibiting the proton pump. The drug whose name end with prazole. The drugs like omeprazole, pantoprazole, esomeprazole, lansoprazole, rabeprazole, drugs whose name end with prazole. The special points to remember, these are drug of choice for not only peptic ulcer disease due to any reason, but also gastroesophageal reflux disease and Zollinger-Ellison syndrome. Okay. Now what is special about these drugs? Number one, these are irreversible inhibitors of proton pump. So they are also known as hit and run drugs. So because of their irreversible action, even irrespective of their half-life, they work for long periods. Second, these are prodrugs. Third, these drugs are inhibitors of CYP2C19. And as we discussed earlier, those should be carefully combined with clopidogrel. They can decrease the efficacy of clopidogrel. And the least potent inhibitors of CYP2C19 are rabeprazole and pantoprazole. These are least strong inhibitors of CYP2C19. Now, proton pump inhibitors, they are usually considered very safe, but if we use them for long periods, they can lead to decrease in vitamin B12 and calcium in the body, so which they can predispose to megaloblastic anemia and osteoporosis. And long-term use of PPIs is associated with increased risk of infections. So this is the first group of drug which we can use in peptic ulcer. Second group we can use are antacids. Antacids like aluminium hydroxide, magnesium hydroxide. These are fastest pain relievers in peptic ulcer, because they will neutralize the already present acid. Aluminium salts can cause constipation, whereas magnesium salts can cause diarrhea. So usually these are combined together to minimize the side effects on the GIT. Then third group of drug are ulcer protectives. Ulcer protectives. So they will form a covering over the ulcer so that ulcer cannot touch the stomach gastric mucosa. So these are drugs like sucralfate and colloidal bismuth substrate. Sucralfate, special point to remember, it requires pH less than 4 to polymerize to become active. So if the gastric pH is not acidic, it will not work. So it should not be combined with antacids or other drugs like proton pump inhibitors. So this is important. Second, sucralfate, it can inhibit the absorption of other drugs which are absorbed in acidic medium like phenytoin. So if we want to give phenytoin with sucralfate, we have to make a minimum gap of 2 hours. Otherwise, phenytoin absorption will be hampered. Okay. Then colloidal bismuth substrate can lead to bismuth toxicity. Then lastly, we can give drugs for Helicobacter pylori, which is the agent bacteria responsible for relapse in peptic ulcer. Anti-H. pylori, we can say H. pylori induced peptic ulcer is treated by triple drug therapy. So triple drug therapy include 2 antibiotics, clarithromycin, amoxicillin, metronidazole. So any 2 out of these plus a proton pump inhibitor. In India, the preferred is CAP therapy, that is clarithromycin, amoxicillin and proton pump inhibitor. Okay. So these are the important points regarding the drugs used in peptic ulcer. Apart from peptic ulcer, second important topic is vomiting. That means the drugs which are anti-emetic drugs. Anti-emetic drugs act by different mechanisms, like they may be anticholinergic drugs, muscarinic blockers, anticholinergic drugs. So drugs like hyoscine, also known as scopolamine. So these drugs are used in motion sickness prophylaxis. They are drug of choice for prophylaxis of motion sickness. If the tablet is taken, it should be taken 30 minutes before journey, and if patch is taken, it should be applied around 24 hours before the journey. Then we have antihistaminic drugs, particularly first generation antihistaminic drug. One of them is doxylamine. It is a drug of choice for treatment of morning sickness, or we can say vomiting of early pregnancy. Then we can use promethazine for motion sickness. Promethazine can be used for prophylaxis of motion sickness. Third group of drugs are 5-HT3 blockers. Their name end with cetron, like ondansetron, granisetron, palonosetron, tropisetron. Drugs whose name end with the cetron. These are drug of choice for chemotherapy induced nausea and vomiting. Anti-cancer drug induced nausea and vomiting, early vomiting in particular, drug of choice are ondansetron like drugs, or drugs which are ending cetron 5-HT3 blockers. Then we have drugs which are D2 antagonist or D2 blockers. The important drugs in this category are domperidone and metoclopramide. The basic difference between the two, domperidone is only D2 blocker, whereas metoclopramide not only D2 blocker but also 5-HT3 blocker and 5-HT4 agonist. Second important thing to remember, domperidone do not cross blood-brain barrier, whereas metoclopramide can cross blood-brain barrier. So what is important, if we give metoclopramide, it can cross blood-brain barrier and block D2 in the brain, which can lead to extrapyramidal side effects like dystonia, tardive dyskinesia we give for long periods. So dystonia like side effects can occur. Second, it can cross blood-brain barrier, so it is not useful in patient with Parkinsonism because it will block dopamine receptors in the brain. So if levodopa induced vomiting is there, the drug of choice is domperidone. Levodopa induced vomiting, drug of choice is domperidone. Okay. Lastly, we have drugs like substance P antagonist. These include drugs like aprepitant, drugs whose name end with pitant, aprepitant, rolapitant, natopitant. These are drug of choice for delayed vomiting due to chemotherapy, or we can say delayed chemotherapy induced nausea vomiting. Drug of choice are pitants. Okay, so that is about the anti-emetic drugs. Then the third important topic in GIT is diarrhea. So the most important and mostly the drug of choice will be ORS. We want to prevent dehydration, and many times if it is viral diarrhea, it will automatically subside. But if it is diarrhea due to infection, If it is due to infection, infection may be entamoeba histolytica or amoebiasis, or it may be bacterial diarrhea. The drug of choice for amoebiasis is metronidazole. Like they are commonly asking the question, a patient develop diarrhea after eating outside food, what is the drug of choice? Mostly it is amoebiasis, so metronidazole. And bacterial diarrhea, the drug of choice are fluoroquinolones. Then diarrhea may be due to tumors like VIPoma or carcinoid syndrome. For these, the drug of choice is octreotide. Octreotide. Now, if the diarrhea is non-specific but it is non-infective, it is not due to infection, we are sure, then we can use anti-motility drugs which decrease the GI motility. Opioids like loperamide and diphenoxylate. Okay, so these are drugs which can be used in diarrhea. Next topic are prokinetic drugs. These are the drugs which increase GI motility and they are used commonly in GERD. The important prokinetic drugs may be D2 blockers like domperidone, metoclopram. Second group are 5-HT4 agonists. The drugs whose name end with pride like cisapride, mozapride, prucalopride. They can be used in GERD. And third, we have erythromycin like drugs, macrolides like erythromycin. They also increase GI motility and can be used in diabetic gastroparesis. Gastroparesis. Okay. Now, the last topic in GIT is inflammatory bowel disease. And we have two main diseases, ulcerative colitis and Crohn's disease. The drug of choice for ulcerative colitis are 5-ASA based preparations like sulfasalazine, olsalazine, etc. Now, if the person do not respond to these drugs, then the drug of choice becomes steroids. On the other hand, in Crohn's disease, directly we start from steroids. Steroids are drug of choice. But if the person do not respond to steroids, then we can use TNF alpha blockers. And the TNF alpha blockers we can use are ACE inhibitor को गोली मारो. ACE inhibitor को गोली मारो means the drugs include adalimumab, sertolizumab, etanercept, infliximab and golimumab. These are anti-TNF alpha drugs. Special point about these drugs increase the risk of infections, so they are absolutely contraindicated if there is hepatitis B or tuberculosis. And these, apart from Crohn's disease, they are also used in rheumatoid arthritis and psoriasis also. Okay. So these are the important points regarding the GI. Our next topic is antimicrobial agents. So the drugs which are against the microorganisms, they can be static or cidal. Static will inhibit the growth of bacteria, whereas cidal will kill them. The most important thing is, in a normal person they are similar, but in a person who is immunocompromised, whose immunity is not there, as suppose the person is on steroid therapy, or the person is having some disease like HIV, or the person is having cancer. So in those patients, for treating the infection, we have to use cidal drugs. Static will not be effective. Okay. The most important cidal drugs you can remember from the mnemonic बेवफा. In Hindi you can remember बेवफा मार डालेगी, तो बेवफा वाली मार डालती हैं. So these include BE for beta lactams, VA for vancomycin, F is fluoroquinolones, and A is aminoglycoside. These are the main cidal drugs. Okay. Now, antimicrobials we can discuss according to their mechanism of action. The first group of drugs include cell wall synthesis inhibitors, and these you can remember as firmly bind to bacterial cell wall. The drugs include phosphomycin, beta lactams, bacitracin, cycloserine, and vancomycin. So these drugs act by inhibiting the bacterial cell wall synthesis. So how they work or what is their mechanism is, you can see that you don't need to remember the mechanism of phosphomycin, cycloserine, bacitrine is usually not asked, but mechanism of vancomycin and beta-lactam is asked. You see they inhibit the formation of cell wall which consists of peptidoglycan. It is a combination of small subunits of muramic acid, glucosamine and pentapeptide. So first of all, these will combine one by one that lead to formation of long chains with the help of an enzyme called as transglycosylase, which is inhibited by vancomycin. So vancomycin inhibits the formation of long chains. On the other hand, after many chains are produced, the two chains will combine with each other, which is called cross-linking. That is done by an enzyme called as transpeptidase. So transpeptidase is inhibited by beta-lactams. So beta-lactams inhibit cross-linking or transpeptidase, whereas other drugs like vancomycin, it inhibits the chain elongation by inhibiting transglycosylase. Okay. So discussing these drugs, the most important among them is beta-lactams. Beta-lactams. So beta-lactams, you can remember that they contain a ring which is called as beta-lactam ring, which is a 4-carbon ring. Along with that, usually have one more ring, which is the second ring. So according to that, we have 4 types of beta-lactam antibiotics. The 4 beta-lactam antibiotics include penicillins, cephalosporins, carbapenims, and monobactams. So discussing these one by one, starting with penicillin. The first used penicillin was penicillin G, but it has lot of limitations. The important limitations being it is not effective orally, need to be given by injection. Then it is very short acting. Then it has very narrow spectrum, mainly for gram-positive bacteria. Even those have developed resistance, and it can cause allergy. The problems can be solved. These were not effective orally because they are broken by the acid in the GIT. So we developed the newer drugs which cannot be broken by acid. These are oral penicillins. They are not effective and not broken by acid in the stomach. So these are remembered as vodka drugs. V for penicillin V, O is oxacillin, D is dicloxacillin, K is cloxacillin, and A is ampicillin and amoxicillin. These are effective orally. Then second, they were short acting, so we add some group to them, which is benzathine or procaine group to them. So when we add benzathine or procaine group, they will hold them in muscles and that will make them long acting. So benzathine and procaine penicillin G are long acting. Benzathine is the longest acting. Second method is we can add probenecid with them. Probenecid inhibit the tubular secretion of penicillin, so they become long acting. Third, they had narrow spectrum, so we developed wide spectrum penicillins, also called as extended spectrum penicillins. And these penicillins you can remember as a city map. A city map, as the map of a city is quite extended, these are extended spectrum. A for amoxicillin and ampicillin, C for carbanicillin, T for ticarcillin, M for magillocillin, A is agilocillin, and P is piperacillin. So apart from A, all other drugs are effective against Pseudomonas. So this is a question asked, which antimicrobials are effective against Pseudomonas. So city map is effective against Pseudomonas. Then the fourth problem of resistance. So resistance we can cater by. Resistance mostly occur because of development of an enzyme called as beta-lactamase. So we have one option that we can add beta-lactamase inhibitor. So beta-lactamase cannot break beta-lactams, and the drug which are beta-lactamase inhibitors are remembered as CST. These are clavulanic acid, sulbactam, and tazobactam. So these are combined with beta-lactams, or we can say penicillins. Clavulanic acid is combined with amoxicillin, sulbactam with ampicillin, and tazobactam with piperacillin. This amoxicillin clavulanic acid combination, which is commonly known as co-amoxiclav, it is drug of choice for lymphangitis. Then second method of taking care of resistance is we can give penicillinase resistant penicillins, and these are remembered as condom drugs. These include cloxacillin, oxacillin, nefcillin, dicloxacillin, and methicillin. These are effective against bacteria which are resistant to other penicillins. Among them, the strongest when we give methicillin means if a bacteria is resistant to methicillin, which is called MRSA, it is likely to be resistant to all beta-lactams. So no beta-lactam is effective against methicillin resistant Staph aureus. Exceptions we will discuss later. Only one exception is 5th generation cephalosporins. All other drugs of penicillin category or beta-lactam category, they are ineffective against MRSA. Only 5th generation cephalosporins are effective. Okay, so this is the problem of resistance. Then lastly, allergy. There is significant cross allergy between different beta-lactams. So if a person is allergic to one beta-lactam, we should not give any other beta-lactam, except monobactams do not show cross allergy. Okay. Now the uses of penicillins. Penicillins are first line drugs for last man. These include listeria, actinomycosis, syphilis, tetanus, meningococcus, and anthrax. Penicillins are first line drug for these infections. Now special for syphilis, the drug of choice is benzathine penicillin G. The dose is 2.4 million units and route is intramuscular. For primary, secondary and early latent syphilis, only single injection is enough. Whereas for late latent and tertiary syphilis, 3 injections are given weekly. That means 1 injection today, 1 next week, 1 next week. Okay. Then in case of meningococcus, for empirical therapy, drug of choice is ceftriaxone. But for confirmed cases of meningococcal meningitis, if it is not confirmed, we give ceftriaxone. If it is confirmed, then penicillin G. Now prophylaxis of meningococcal meningitis, the drug of choice now is ciprofloxacin. It can be given orally, and it is preferred in mass prophylaxis because can be given to large group of peoples. But most effective drug is ceftriaxone. But because of injectable route, it is not suitable for mass chemoprophylaxis. But ceftriaxone is safe in pregnancy and children, whereas ciprofloxacin cannot be given in pregnancy and children. Rifampicin now is not preferred for prophylaxis of meningococcal meningitis. Okay. So this is about the meningitis. Then coming to gonococci, gonorrhea. For gonococcal urethritis, the drug of choice is ceftriaxone. But if there is non-gonococcal urethritis, the drug of choice is azithromycin. And if there is doubt that both gonococcal and non-gonococcal urethritis is present and we need to give one drug only, it is azithromycin. Okay, so that is about penicillins. Then coming to cephalosporins. Cephalosporins are divided into different generations. Their names start with ceph only. Now special point about cephalosporins to remember, some cephalosporins are secreted in bile, so they are safe in renal failure. These are cephalosporins whose name end with 1. So cefoperazone and ceftriaxone. The drugs whose name end with 1, they are secreted in bile, so safe in renal failure. The question asked is which other drugs or other antimicrobials are safe in renal failure. So you can remember them as safe in the renal disease. The mnemonic itself say these are safe in the renal disease because they are secreted in bile. So cephalosporins which are secreted in bile, that means cefoperazone and ceftriaxone. T for tigecycline, R for rifampicin, E is erythromycin, N is nefcillin, A is ampicillin, L is lincosamide, which is clindamycin, and D is doxycycline. These are safe in renal failure because they are secreted in bile. Then second important point about cephalosporins to remember, which cephalosporins are effective against Pseudomonas. So you can remember the cephalosporins having P in the name are effective for Pseudomonas like cefepime, cefpirom, cefoperazone, and one without P, which is ceftazidime. These are effective against Pseudomonas. Ceftazidime is most effective cephalosporin against Pseudomonas. And from the name you can remember it's saying जिद्दी है, Pseudomonas को नहीं छोड़ेगी. Okay. Then some cephalosporins, they can increase the risk of bleeding because they decrease prothrombin. So most important among them to remember is cefoperazone, moxalactam, cefotita. These can increase the risk of bleeding. Okay, and same cephalosporins can also cause interaction with alcohol known as disulfiram like reaction. Okay, so that is important about the cephalosporins. Then third group of beta lactams are carbapenims. The main drug in this case is imipenem. Imipenem is broken down by an enzyme called as dehydropeptidase in the kidney. So if we give it alone, it is broken down, it becomes ineffective. But if we combine with inhibitor of this enzyme, which is cilastatin, then imipenem is effective. So imipenem is always given with cilastatin, and this combination it is used for wide range of organism including gram positive, gram negative as well as anaerobic bacteria. The main side effect of imipenem is seizures. So it is avoided in epileptic patients, and imipenem can cause seizures. So epileptic patients it should be avoided. Then we developed the newer drugs in this category like meropenem, ertapenem and doripenem. So they have same spectrum like imipenem. The advantage is they do not require cilastatin because they are not broken by dehydropeptidase, and they have lesser risk of causing seizures. So imipenem has maximum risk of seizures among the carbapenims. Now carbapenims, they are drug of choice for extended spectrum beta lactamase producing bacteria, particularly Klebsiella bacteria. Okay. Now they are drug of choice for ESBL producing bacteria, but the problem is if a bacteria is resistant to ESBL also, so that bacteria produce an enzyme known as metallo-beta-lactamase. The bacteria which produce metallo-beta-lactamase, drug of choice is colistin because these are resistant even to carbapenims. Okay. Then last group of drugs we have monobactams. Monobactam, we have only one drug called as agtrione. It has two special points. One, unlike penicillins, this is effective only against gram-negative bacteria including Pseudomonas. It is not for gram-positive. And second, it do not show cross allergy. So जब पेनिसिलिन्स को पता लगा कि बीटा लैक्टम ग्रुप में ही हमसे डिफरेंट दवाई आ गई है, तो वो इसके पास गए और इसको पूछते हैं कि अजी तेरा नाम तो बता, तो हमने इसका नाम रख दिया अजी तेरा नाम, दैट मीन्स एजिट्रियोना. ओके. Then moving to vancomycin. Vancomycin, the special points to remember about vancomycin, it is also cidal drug, but it should be given by IV route. Only oral indication of vancomycin is pseudomembranous colitis. Now vancomycin is not the drug of choice for pseudomembranous colitis. For pseudomembranous colitis, now the drug of choice is fidaxomicin. Fidaxomicin is now the drug of choice. It has highest chance of preventing the relapse. Pseudomembranous colitis is caused by Clostridium difficile. Okay. Then vancomycin can be given IV for most other indications. Vancomycin is drug of choice for MRSA. If a bacteria is resistant to vancomycin, it is called VRSA. The drug of choice for VRSA is daptomycin. For most indications, daptomycin is drug of choice. But daptomycin is not effective in lung conditions like pneumonia because it is metabolized by surfactant, it becomes inactive. So for pneumonia, VRSA induced pneumonia, the drug of choice is linezolide. Okay. The major side effect of vancomycin, it is nephrotoxic and ototoxic. So this is about the first group of drugs inhibiting cell wall synthesis. Then second group of drugs are protein synthesis inhibitors. The important drugs in this category include tetracyclines, macrolides, and aminoglycosides. So starting with the tetracyclines, the drug whose name end with the tetracycline cycline are tetracyclines. So tetracyclines जो हैं वो कपिल देव को नहीं देनी है. The disadvantage problems of tetracyclines remembered as Kapil Dev: kidney failure. Tetracyclines are contraindicated in renal failure except doxycycline. We discussed it is secreted in bile, so it is safe in renal failure. They have anti-anabolic action. They can cause loss of muscle mass. They are phototoxic. Maximum phototoxicity is caused by demaclocycline. They can cause insipidus, means diabetes insipidus, means they decrease ADH from the posterior pituitary. Again, maximum is with the demaclocycline. L is liver disease. They are contraindicated in liver disease. D is dentition and bone problem. So tetracyclines are contraindicated in pregnancy and children because they can affect growing teeth and bone. So if we give them after expiry date, they can cause Fanconi syndrome. So expired tetracycline should not be given. And V for vestibular dysfunction, which is maximum with minocycline. Minocycline has maximum vestibular dysfunction. But tetracyclines, they are contraindicated और विंग से कपिल देव को नहीं देनी है, but श्रीलंका वालों को तो दे सकते हैं. So these are the uses of tetracycline. S for SIADH, syndrome of inappropriate ADH secretion. The most effective tetracycline is demaclocycline, but we commonly prefer Vaptans for these. Then for rickettsia, tetracyclines are drug of choice. Epidemic typhus, endemic typhus, Rocky Mountain spotted fever, scrub typhus, drug of choice are tetracyclines like doxycycline. Then inguinal granuloma inguinale, which is also known as danovenosis. Tetracyclines are first line drugs. Then lymphogranuloma venereum, another STD, they are drug of choice. Atypical pneumonia, they can be used but not the drug of choice. K for cholera, tetracyclines are drug of choice. And A for amoebiasis, we can use tetracyclines. Now the resistance to tetracycline occurs mainly because of development of efflux pumps. So we have developed a drug called tigecycline, which is resistant to these efflux pumps. Tigecycline is resistant to these efflux pumps. Tigecycline otherwise is like tetracyclines, but tigecycline is not effective against pseudomonas. And second, it is secreted in bile, so it is safe in renal failure. It is a broad spectrum drug like tetracycline. Okay. Then second group of protein sensitive inhibitors. Remember, most of the protein sensitive inhibitors are static drugs, including tetracycline, tigecycline. Now second group are macrolides. The name of these drugs end with thromycin. Examples like erythromycin, roxithromycin, clarithromycin, and azithromycin. One important drug whose name do not end with thromycin is fidaxomicin. And this is now the drug of choice for pseudomembranous colitis, as we discussed earlier. Now thromycins, the special point to remember, these are drug of choice for 4 conditions remembered as CLAP, chancroid and corynebacterium, that means diphtheria. So they are drug of choice for diphtheria and chancroid. Then Legionella, so they are drug of choice for Legionnaire's pneumonia also. Then atypical pneumonia, they are drug of choice, and pertussis or whooping cough, they are drug of choice. So these are important. They are drug of choice for CLAP, corynebacterium chancroid, Legionella, atypical pneumonia, and pertussis. Now, apart from macrolides, the third group is aminoglycosides. Aminoglycosides are the only sidal protein synthesis inhibitors, others are static. Aminoglycosides are injectable, they are not effective orally, either given IM or IV. Aminoglycosides require oxygen for entry in the bacteria, so they are ineffective against anaerobic bacteria. Not effective against anaerobic bacteria. Now, aminoglycosides, the major side effects include nephrotoxicity, ototoxicity, and neuromuscular blockade. These are the main side effects of aminoglycosides. Plus, aminoglycosides are highly teratogenic drugs, so they are contraindicated in pregnancy. Aminoglycosides are contraindicated in pregnancy. The examples of aminoglycosides include streptomycin, gentamicin, kanamycin, etc. Okay. So this is the second mechanism of antimicrobials. That means drugs inhibiting protein synthesis. One more protein synthesis inhibitor drug is linezolide. Linezolide. It is also a static drug. Linezolide can cause peripheral neuropathy as a side effect. And linezolide, it is mainly for gram-positive bacteria. In fact, it is drug of choice for VRSA-induced pneumonia. VRSA pneumonia, the drug of choice is linezolide. Okay. Then moving to the third mechanism, drugs inhibiting metabolism, mainly folic acid metabolism. So three substances, pyridine, PABA, and glutamate, they combine together with the help of enzyme folic acid synthase to produce dihydrofolic acid. Dihydrofolic acid is converted to tetrahydrofolic acid with the help of enzyme dihydrofolic acid reductase, and this help in formation of DNA. The drug inhibiting the first enzyme folic acid synthase are sulfonamides, whereas drug inhibiting second enzyme is trimethoprim and pyrimethamine. Now, individually, both these groups are static drugs, but if we combine sulfonamide with one of these, trimethoprim or pyrimethamine, the combination is cidal. Okay. Now, important point regarding sulfonamides. Sulfonamides, we know they can cause skin rash as a side effect. Sulfa allergy is a known problem. So, you can remember important point about sulfonamides by remembering the ABC of rash. A for aplastic anemia. Sulfonamide can cause aplastic anemia, that means anemia, leukopenia, thrombocytopenia. Second, they have high plasma protein binding, so they can cause displacement of bilirubin from the plasma protein binding sites, and this free bilirubin can enter the brain and can cause kernicterus in newborn babies. So sulfonamides are contraindicated in newborn babies and in late pregnancy. Then C for crystalluria. Sulfonamides are insoluble in the acetic urine. They can come as crystals, and the most soluble will have minimum crystal formation. So most soluble sulfonamide is sulfasoxazole. So it has minimum risk of crystalluria. Then R for rash, they can cause skin rash like Stevens-Johnson syndrome. Sulfonamides are metabolized by acetylation. They can cause SLE, and they can cause hemolysis in patients with G6PD deficiency. Sulfonamide can cause hemolysis in these patients. Okay. Then second, coming to combination of sulfonamide with trimethoprim, the combination is co-trimoxazole. The name says it is a combination of trim. Trim means trimethoprim with oxazole means sulfamethoxazole. Combination of trimethoprim with sulfamethoxazole. Now this combination, it is present as 1:5 ratio in the tablet, but absorption of both is different. So when it reaches the blood, the ratio become 1:20, which we want. It is the ideal ratio for the best bactericidal activity. Now co-trimoxazole, it is drug of choice for Punjab National Bank PNB, which is pneumocystis, nocardia, and Burkholderia cepacia. Co-trimoxazole is drug of choice for these infections. Then second combination, sulfadoxin with pyrimethamine. This combination is used mainly for parasites like malaria and toxoplasmosis. Okay. So this is the third mechanism. Then the last main mechanism is drugs inhibiting DNA gyrase. The drugs are fluoroquinolones. Their name end with floxacin. These are cidal drugs and can be given orally also. The special points to remember: bioavailability. Maximum oral bioavailability is present in levofloxacin. whereas minimum oral bioavailability is present in norfloxacin. Second, floxacins, they can induce seizures, particularly in epileptic patients, so they are avoided in seizure disorder or epilepsy. The minimum risk of seizures is seen with moxifloxacin. Others have high risk. Then fluoroquinolones are contraindicated in pregnancy and children because they cause tendon damage and cartilage damage. So tendon and cartilage damage can occur if we give to growing baby or in pregnancy. So they are contraindicated. Then fluoroquinolones are contraindicated in renal failure except PMT. रिमेंबर अगर किडनी फेल होगी तो भी पीएमटी दे सकते हैं. दीज आर पीफ्लॉक्सासिन, मॉक्सीफ्लॉक्सासिन एंड ट्रोवाफ्लॉक्सासिन बिकॉज दे आर मेनली मेटाबोलाइज्ड बाय लिवर एंड बिकॉज दे आर नॉट मेनली गोइंग टू किडनी, सो दे आर इनइफेक्टिव अगेंस्ट urinary tract infection. So they are not good for UTIs because they are not going to kidney too much. Then there is a group of fluoroquinolones which is called as respiratory fluoroquinolones. We remember them as oh my god fluoroquinolones. So these include ofloxacin, moxifloxacin, gatifloxacin and levofloxacin. These are effective against almost all respiratory pathogens including gram-positive, gram-negative bacteria, anaerobic bacteria as well as Mycobacterium tuberculosis. Okay? And atypical bacteria like Mycoplasma etc. So they are respiratory fluoroquinolones. Okay? Now after discussing these drugs which act by different mechanisms, one of the most important problem in antimicrobial drugs is development of resistance. So the various mechanism by which the drugs may develop resistance is first of all by developing the inactivating enzymes. So the drugs which develop resistance because of these mechanisms are remembered as ABC, A for aminoglycosides, B for beta lactams and C for chloramphenicol. The resistance occur because of inactivating enzymes. Second, the resistance can occur due to altered target. The target is changed like in case of MRSA, VRSA and in case of fluoroquinolones, DNA gyrase is changed. Then efflux pumps, the bacteria may develop efflux pumps particularly in case of tetracyclines. Bacteria may develop decreased permeability. The drug may not enter inside the bacteria particularly in case of aminoglycosides. Then there may be altered metabolism. So bacteria may start utilizing the preformed folic acid as in case of sulfonamides. Okay. Then another important thing to remember in antimicrobials is not which is the drug of choice for which bacteria, but which drug is not effective for which bacteria. So this is commonly asked. So for Pseudomonas, remember vancomycin is not effective. Drug of choice for Pseudomonas is a combination of a beta lactam which is effective against Pseudomonas with aminoglycosides. But remember vancomycin is not effective. Then for MRSA, remember drug of choice is vancomycin, but beta lactams are not effective except fifth generation. No beta lactam is effective against MRSA except fifth generation cephalosporins. Then for anaerobic bacteria, aminoglycosides are not effective, but the drug which is drug of choice for anaerobes is metronidazole. Metronidazole is drug of choice. For typhoid fever also, aminoglycosides are not effective, but drug of choice is ceftriaxone. Ceftriaxone is drug of choice. And for mycoplasma, remember mycoplasma do not have cell wall. So any drug which is cell wall inhibitor like beta lactams, vancomycin, they are not effective. The drug of choice for mycoplasma are macrolides like azithromycin. Okay. So these are the important to remember which drugs are not effective. Okay. Now we can discuss the treatment of specific diseases like mycobacterial diseases, particularly tuberculosis, the most important. For TB, we have drugs which we can divide into first line and second line drugs. First line drugs may be essential first line drugs which are HRZE. We all know isoniazid, rifampicin, pyrazinamide, ethambutol. And there may be supplemental first line drug which is streptomycin. First discussing about first line drugs. First, a table is important. Make a table of HRZES. Out of the which are sidal, which are static, first of all, except ethambutol, which is static. All other drugs are sidal. Then which type of bacteria they affect, intracellular or extracellular? Pyrazinamide is only for intracellular, streptomycin only for extracellular. Rest of the drugs are effective against both bacteria. Then hepatotoxicity. Isoniazid, rifampicin and pyrazinamide are hepatotoxic. Ethambutol and streptomycin not. Pyrazinamide is most hepatotoxic. Lastly, safety in pregnancy. Isoniazid, rifampicin and ethambutol are absolutely safe. Pyrazinamide is avoided as far as possible, but streptomycin is absolutely contraindicated in pregnancy. So sometimes the question is asked, which of the following anti-tubercular drug should be omitted in pregnancy, whether it is normal TB or it is XDR TB or MDR TB, aminoglycoside should be removed. Okay. Then which drug is best for which bacteria? For fast growing bacteria, the best drug is isoniazid. For spurters, the best drug is rifampicin, and for slow growing bacteria, best drug is pyrazinamide. Okay. Then special point about individual drugs. If we talk about isoniazid, first of all, mechanism of action, it is inactive. Isoniazid is first activated by a bacterial enzyme called catalase peroxidase, which is formed by CAT-G gene of the bacteria. It will activate isoniazid and that will inhibit mycolic acid synthesis. Mycolic acid synthesis. Okay. Now isoniazid, special point to remember, it apart from being hepatotoxic, it will cause deficiency of pyridoxine. So pyridoxine is always given with isoniazid, and deficiency of pyridoxine can lead to peripheral neuropathy. Then isoniazid is one of the ship drugs, if you remember. So sulfonamide, hydrolysine, isoniazid, procainamide. Special point about ship drugs: one, they are metabolized by acetylation, and second, they can cause SLE like side effects. Then rifampicin, special points to remember. First of all, rifampicin mechanism is it inhibit RNA polymerase. It bind to beta subunit of RNA polymerase and inhibit it. RNA transcription will not occur. Then second thing, rifampicin is always given empty stomach. Food interfere with the absorption. It is a powerful enzyme inducer. It can increase metabolism of large number of drugs, including oral contraceptive pills. So failure of contraception can occur. Rifampicin is a broad spectrum drug. It is effective against many gram-positive as well as gram-negative bacteria apart from tuberculosis. It is first-line drug for treatment of leprosy also. Then it can cause discoloration of secretions, particularly orange-colored urine can occur. Then apart from rifampicin, we have pyrazinamide or Z. Pyrazinamide, most important point to remember, it causes hyperuricemia. Ethambutol, E for eye, it causes eye problem, red-green color blindness. Red-green color blindness can occur with ethambutol. And streptomycin is an aminoglycoside, so can cause nephrotoxicity, etc. Then moving to second line drugs. Second line drugs, some of the drugs include ethionamide, cycloserine, and para-aminosalicylic acid. Special point, ethionamide is hepatotoxic. Cycloserine cause neuropsychiatric side effects, and PAS cause hypothyroidism. Then second group of second line drugs we have are fluoroquinolones, particularly ofloxacin, moxifloxacin, getifloxacin, and levofloxacin. Third group are injectable drugs like kanamycin, capreomycin, and amikacin. All these are avoided in pregnancy. Then we have drugs like linezolide and clofazimine. Linezolide is mainly used for VRSA and now it's being used in TB. Clofazimine is mainly used in leprosy, now being used in TB. Then we have some new drugs in leprosy. These include bedaquiline, delamenite, and pretomenite. Bedaquiline inhibit Mycobacterium ATP synthesis, whereas dalomenide and pretomenide, they act by inhibiting mycolic acid synthesis. Now, all these drugs can cause QT prolongation as a side effect. On the other hand, pretomenide, it is used in a special combination called as BPAL therapy for treatment of Xtia tuberculosis. So, this combination include bedaquiline, pretomenide and linezolide. Okay. Now, coming to treatment of TB. For drug sensitive TB, now there are no categories, category 1, 2, all categories, they are treated similarly. The treatment is for 2 months 4 drug HRZD and for 4 months 3 drugs HRE. Then drug resistance TB, you don't need to remember the treatment but definitions in the drug resistance TB, particularly MDR TB. वैसे MDR TB when the bacteria is resistant to both isoniazid and rifampicin, and we say XDR extensively drug resistant TB, extensive drug resistant TB. It is said when the bacteria is resistant to both isoniazid and rifampicin, that means minimum MDR plus minimum one of the fluoroquinolones plus minimum one of the injectable drugs. Then we say it is XDR tuberculosis. Okay. So that is about anti-tubercular drugs. Then coming to leprosy. Now the treatment of multibacillary as well as paucibacillary leprosy, the drugs used are same. What are the drugs used? For an adult, the drugs used are rifampicin 600 milligram once a month, clofazimine 300 milligram once a month. Both of these are supervised. Then 50 milligram of clofazimine once daily, which is unsupervised, and dapsone 100 milligram once a day, again unsupervised. These are unsupervised. For multibacillary leprosy, this therapy continued for 12 months, that means 1 year, and for paucibacillary leprosy, this is for 6 months. The drugs used are same for both now. Okay. Then coming to malaria. We know malaria caused by Plasmodium. Main parasites are Vivax and Falciparum. So this is our blood. First of all, the parasite, when Anopheles mosquito bites, it sends the sporozoite into the blood, which quickly goes to the liver. It may become dormant here when it is called as hypnozoites, or it may start multiplying. When it multiplies, it will come back into the blood, but now inside the RBCs. Inside the RBCs, it will keep on multiplying, rupture the RBC, cause the symptoms, and then it can convert into gametes. Okay. So the 4 stages in the malarial parasite life, we can say this is called as erythrocytic stage. This is called as gametocytic stage. This is exoerythrocytic stage, and this is pre-erythrocytic stage. So all these stages have different functions, so the drugs will have different rules. Now pre-erythrocytic stage, it is the cause of malaria. So if we use a drug, that will be used for causal prophylaxis, and the drug we use for this is primaquine. Then exoerythrocytic stage, it is responsible for relapse. So if we use a drug which kills this stage, we can use it for radical cure. And the drug used is again primaquine. Primaquine need to be given for 2 weeks for radical cure. Whereas new drug has been found which is called as tefenoquine, which need to be given as a single dose for radical cure. Both these drugs, they can cause hemolysis in G6PD deficiency. So they are avoided in pregnancy and any patient with G6PD deficiency. Then we have gametocytic stage. Again, the drug which can kill this is primaquine. It is used to prevent transmission of malaria. Primaquine single dose can kill gametes of all the 4 species of parasite. Then lastly, erythrocytic stage, it is responsible for causing these symptoms. So the drug can be used to treat malaria, that means clinical cure, as well as for prophylaxis of malaria. Now the drugs which can kill the erythrocytic stage may be fast acting or they may be slow acting. Fast acting drugs we remember as machhar drugs. We have mefloquine, atovaquone, chloroquine, halofentrin, artemisinin, and Rescue Q, that is market name of quinine. Whereas slow acting drugs like sulfadoxine, pyrimethamine, proguanil, doxycycline and clindamycin. Now what is special to remember is chloroquine is mostly drug of choice for Plasmodium vivax malaria or whenever the parasite is sensitive. But for resistant malaria, we mostly prefer artemisinin like artesunate. Now coming to treatment of malaria, if the parasite is sensitive, whether it is vivax or falciparum, the drug of choice is chloroquine, and vivax mostly are sensitive. But in case of resistant parasite, which is chloroquine resistant, the treatment of choice is ACT, artemisinin based combination therapy. So two combinations are used. One is artesunate plus sulfadoxine pyrimethamine, and second is artemether plus lumefantrine. Now this combination is drug of choice for all over India, whereas in northeastern states we mainly prefer artemether lumefantrine combination. The reason being sulfadoxine pyrimethamine is mostly not effective in northeastern states against malarial parasite. Now this is about uncomplicated malaria, but if there is complicated malaria like cerebral malaria, if there are symptoms of cerebral malaria like person has altered sensorium, then the drug of choice is artesunate IV. Remember, intravenous artesunate is drug of choice for complicated malaria. Okay. Then coming to prophylaxis of malaria, for if a person is planning to stay for more than 6 weeks in the endemic area, the preferred drug is mefloquine. If the person is planning to stay for less than 6 weeks, the preferred drug is doxycycline. So both these therapies should be continued minimum 4 weeks after the person has returned back to non-endemic area. Okay. So these are the important anti-malarial drugs. Then moving to antiviral drugs. We have several viruses, the most important virus being HIV. So how HIV cause infection? It infects CD4 cells. So this is HIV. This is the virus having genetic material as RNA. First of all, virus fuse with the human cell and send the genetic material, means RNA inside. This RNA is converted to DNA, double stranded DNA, with the help of enzyme reverse transcriptase. This reverse transcriptase forms the DNA, but it need to combine with human DNA. So this combination of viral DNA and human DNA, it is with the help of an enzyme called as integrase. Now this DNA become active and start producing proteins, but proteins are mostly inactive. So to make these proteins active, we need an enzyme called as protease. Protease enzyme is required. So all these proteins become active, the complete virus will be established and that can infect other cells. So the drugs which can be used in HIV, they may be fusion inhibitors, reverse transcriptase inhibitors, integrase inhibitors and protease inhibitors. 4 type of drugs. We'll discuss one by one. Fusion inhibitors. We have 3 type of fusion inhibitors. One which bind to GP41 present on the virus. Second which bind to CCR5 co-receptor present on the human cells, and third which bind to CD4 receptors present on the human cells. The drug which bind to GP41 is called as enfuvirtide. The name says it bind to envelope and fusion of the virus with the T cell is inhibited. The drug binding to CCR5 is maraviroc. And the drug which is binding to CD4 is the monoclonal antibody called as ibalizumab. So both of these drugs are injectable, ibalizumab as well as enfuvirtide. Enfuvirtide subcutaneous, ibalizumab IV, whereas maraviroc is oral. So first group is fusion inhibitors. Then second group are reverse transcriptase inhibitors. They may be NRTI or NNRTI. The important NNRTI drugs we have are AND drugs, which is efavirenz, nevirapine, and delavirdine. Whereas NRTIs may be nucleotide or nucleoside. We have only one nucleotide RTI, which is T for tenofovir. And nucleoside RTIs include drugs ending with woodin like zidovudin, lamivudin, stavudin. We have didanosine, abacavir, and drugs ending with cetabin like gelcetabin and emtricitabine. Now all these drugs, they can cause, even tenofovir, they can cause pancreatitis and peripheral neuropathy as adverse effects. Special point, zidovudin can cause bone marrow suppression. Didanosine has maximum risk of pancreatitis. Abacavir can result in myocardial infarction. Now, some of these anti-HIV drugs are effective against hepatitis B virus also. So, some drugs which are effective against both, they are remembered as tenofovir, lamivudin, and emtricitabine. So these drugs, they are remembered as let drugs. Let us treat hepatitis B also. Okay. Second group are reverse transcriptase inhibitors. Then third group are integrase inhibitors. The name of these drugs end with tigravir. As the name contains, tigra means integra. Okay. So drugs like elvitegravir, dolutegravir, raltegravir, these are tigravirs, that means integrase inhibitors. They can be given orally. Then lastly, we have protease inhibitors. Drugs ending with navir like ritonavir, sequinavir, emprinavir, atazanavir, and many other navirs. The special point about navirs are these are metabolized by a CYP3A4 enzyme, as well as they are inhibitors of the same enzyme. So these drugs can inhibit each other's metabolism. The strongest CYP3A4 inhibitor is ritonavir. So it is added to other protease inhibitors to boost their effect. So it is used as a booster drug. Okay. Now coming to treatment of HIV. Now sometime a patient is having HIV with tuberculosis. So if both are present together, then first we will start anti-tubercular drugs, and after 2 weeks we will start anti-HIV drugs. Okay. Now if HIV is present, first of all patients should be treated. It does not depend upon CD4 level now. So whatever may be the CD4 level, every patient required treatment, and the treatment required is lifelong. Now with which drug to treat? The guidelines say that we need to give minimum 3 drugs, which is mostly 2 NRTI and 1 drug from either NNRTI category or integrase inhibitor category. Okay. The preferred therapy now is TLE, that is tenofovir, lamivudin and efavirenz. Tenofovir, lamivudin and efavirenz. Okay. Then coming to post-exposure prophylaxis, mostly seen in healthcare workers if there is needle stick injury. So what we will say, first wash with soap and water. Wash the affected area with soap and water. Get the baseline HIV testing done, the CD4 count done now and 6 weeks later also, now and 6 weeks later. Then if we need to start the therapy, we have to start within 72 hours. And the recommended is 3 drug therapy, which is tenofovir, lamivudin and one of the protease inhibitors or integrase inhibitors. That means either navir or tigravir, one of them. Okay. So these are important points regarding the anti-HIV drugs. Then moving to the second important virus, which is herpes virus. So in herpes virus, first of all, for herpes simplex virus type 1, herpes simplex virus type 2 and varicella zoster virus, the drug of choice is acyclovir. Acyclovir. The other drug which we can use are gencyclovir or valacyclovir. Now how these drugs work is, these drugs, They are inhibiting the DNA formation, or we can say DNA replication in the virus. Now, how they inhibit DNA replication is they are thymidine analogs. So they first need to be activated by thymidine kinase. They need to be phosphorylated. So acyclovir is converted to acyclovir phosphate with the help of viral thymidine kinase. Then they become diphosphate and triphosphate with the human enzymes, and then they will inhibit DNA replication. But important thing is viral thymidine kinase, if it undergo mutation, there will be resistance. So that is the main problem, the resistance can occur. So to prevent that chance, we have developed a drug which is called as phoscarnet, which do not require activation by viral thymidine kinase. No viral thymidine kinase is required, so it will be resistant to these mutations. So even if mutation is present, it will be effective. But this drug is very toxic. Although it is effective against varicella zoster as well as CMV, but it is very toxic. It can cause renal failure, it can cause genital ulcers, and it can cause hypocalcemia. Okay. Then another herpes virus is cytomegalovirus, the drug of choice for which is Jancyclovir. Now, apart from herpes viruses, the next important virus is influenza virus. We have three mechanisms by which the drugs may work. One, the drugs which inhibit uncoating of the virus. The drugs include amantadine and rimantadine. They inhibit uncoating. Second, we have a drug which inhibit neuraminidase inhibitor. The drugs include oseltamivir, the drugs ending with mivir, zanamivir, and piramivir. These are drug of choice for bird flu and swine flu. H1N1 and H5N1, they are drug of choice. Then third, we have a drug which is polymerase inhibitor. It's a new drug which is called as baloxavir. It's a new drug. It has been approved as a single dose treatment of influenza. Okay. So these are drugs for influenza virus. Next is hepatitis virus. Hepatitis B virus, the drug of choice is entecavir or tenofovir, any one of them. Then hepatitis C virus. Previously we did not have any oral drug. Now all oral therapy is preferred. And the oral drug for hepatitis C virus, they are of three categories. One is protease inhibitors. The name will end with pravir, like grazopravir, paritapravir, any drug ending with pravir, bocepravir. Then we have drugs which inhibit RNA polymerase, NS5A or NS5B. Two type polymerase inhibitors. 5A inhibitors, the name end with asvir, like ladipasvir, daclatasvir. And NS5B inhibitor, the name end with buvir, like sofosbuvir, dasabuvir, the name ending with buvir. Okay. So 5A inhibitors, the name you can remember as 5A, and buvir is B. Okay, vir means virus. So these are important points regarding antiviral drugs. We have antihelminthic drugs. Antihelminthic, platyhelminthus, that means tapeworms and flukes. The drug of choice for all the tapeworms and all the flukes is praziquantel, except one tapeworm which is dog tapeworm or echinococcus, for which the drug of choice is albendazole, and one fluke which is liver fluke, the drug of choice is triclabendazole. Similarly, for nematodes, almost all the nematodes like ascaris, roundworm, hookworm, pinworm, all of them, the drug of choice is albendazole. But exception for filarial worm, the drug of choice is diethyl carbamazine, and for strongyloids and onchocerca, the drug of choice is ivermectin. Okay. Now the next topic is antifungal drugs. Now, antifungal drugs we can divide according to the mechanism of action. First, the drug which act on membrane. In the membranes, we have first drug which is amphotericin B. It bind to ergosterol, create pores in the membrane and kill the fungus. The important thing is this is the main sidal drug. Okay? So it is drug of choice for almost all serious fungal infections, including mucormycosis. And all serious fungal infections, it is a drug of choice. Then amphotericin B, it can cause nephrotoxicity and infusion related reactions. Most common adverse effect is infusion related reactions, but most common dose dependent adverse effect is nephrotoxicity. So apart from amphotericin B, the second method of acting on the membranes, we have, if we see ergosterol, it is formed from lanosterol. Lanosterol is formed from a compound called squalene. So we have two enzymes. One is squalene epoxidase, which convert squalene to lanosterol, and second lanosterol 14 alpha demethylase, which convert lanosterol to ergosterol. The drug inhibiting the first enzyme is terbinafine. Terbinafine. It is mainly used for dermatophytosis. Drug inhibiting second enzyme are azole group of drugs. So both of these are acting by membranes. So important azoles group of drugs are fluconazole, drugs ending with conazole, fluconazole, itraconazole, voriconazole, posaconazole. These are conazoles. The special point to remember, fluconazole is a drug of choice for Candida and Cryptococcus, particularly non-CNS. Then voriconazole is a drug of choice for aspergillosis. These are azoles. Then second group of drugs, they can act on DNA. The drug which is acting on DNA, number one is griseofulvin. It acts on mitotic spindle. Griseofulvin is a static drug. It can cause disulfiram-like reaction, intolerance to alcohol, and it is used for dermatophytosis. Then second, we have drug like flucytosine, which can act on DNA. It inhibits DNA polymerase. Then apart from this, we have drug which can inhibit protein synthesis of the fungus, which is tavovorol. Tavovorol. It inhibits protein synthesis in the fungus. Then we have cell wall synthesis inhibitors in the fungus. Fungal cell wall synthesis inhibitor drugs include echinocandin, the drug like caspofunkin. Now some of the drugs which are used in the dermatophytosis, they can be applied as nail lacquers. Nail lacquers. So the drugs which are used as nail lacquers for fungal infection are remembered as CEAT, cyclopyrox, olamine, afinaconazole, amorolofine, and terbinafine. These can be used as nail lacquers. Okay, so these are important points regarding the antifungal drugs. The next topic we have is, last topic in antimicrobial, is antiparasitic drugs. Among the parasites, the important being, first we have amoebiasis. Amoebiasis, we know drug of choice for luminal amoebiasis is diloxanide furoate, and drug of choice for intestinal and extraintestinal amoebiasis like hepatic amoebiasis is metronidazole group of drug. Now metronidazole group of drug, the major side effect of this is disulfiram like reaction. But metronidazole, it is used for several conditions which you can remember as Gupta, giardiasis, and Gardnerella vaginalis, that means bacterial vaginosis. For these two conditions, it is a drug of choice. So commonly the question is asked, there is vaginal discharge, usually greenish discharge, and there is presence of clue cells, as well as whiff test is positive. If we put potassium hydroxide on the vaginal discharge, fishy odor occurs. So the drug of choice will be metronidazole. Then ulcer, peptic ulcer, it can be used. Then we have pseudomembranous colitis. It is not preferred but can be used. Trichomoniasis, it is drug of choice. And anaerobic bacteria, metronidazole is drug of choice. Okay. So this is about the amoebiasis, first parasite. And second of the parasite, it is leishmania, which cause Kala Azar. The drug of choice for Kala Azar is liposomal amphotericin B. Okay. For post Kala Azar dermal leishmaniasis, we can use miltefosine. Next parasite is trypanosomiasis. Trypanosoma. It can be African, which is causing sleeping sickness, or it can be South American, which is known as Chagas disease. साउथ अमेरिका वाले झकास होते हैं इसलिए चागास डिजीज कहते हैं. अफ्रीकन ट्रिपैनोसोमियासिस इन अर्ली स्टेजेस वी यूज सुरामिन. सो यू कैन रिमेंबर शुरू में सुरामिन दे देते हैं. फॉर लेट स्टेजेस वी यूज मिलार्सोप्रोल. सो रिमेंबर अगर मेले में जाएंगे तो लेट हो जाएगा. एंड फॉर चागास डिजीज वी यूज बेंजनिडाजोल. बेंजनिडाजोल, रिमेंबर झकास आदमी है तो मर्सिडीज बेंज चलाएगा, बेंजनिडाजोल. Then lastly we have now one of the last virus which is very important these days is COVID-19. It is novel coronavirus causing infection in humans. So for COVID-19 plenty of drugs were tried, but only one drug is FDA approved, and that is remdesivir. Remdesivir, it is a RNA dependent RNA polymerase inhibitor. It need to be given intravenously. So given only for selected patients who are already admitted and on oxygen therapy. Okay. But it does not provide mortality benefit. The only drug which decrease mortality in COVID-19 are steroids. Only drugs which decrease mortality in COVID-19 are steroids. Okay. The next topic is anti-cancer drugs. So we can divide these drugs broadly into cytotoxic drugs, which are non-specific cell drugs which will kill the cells, almost all cells including cancer cells. And second, we have targeted drugs. Now cytotoxic drugs, they kill the cells, so that are very toxic, so they can cause lot of side effects. In particular, their main side effects include hyperuricemia, bone marrow suppression leading to anemia, leukopenia, thrombocytopenia, diarrhea, and alopecia. These are common side effects of almost all cytotoxic drugs. Okay. Now cytotoxic drugs, we can divide them into whether they are cell cycle specific or non-specific. So we have drugs which are S phase specific, we have M phase specific, and we have non-specific. S phase specific drugs are mainly anti-metabolites. So these drugs, they may act by inhibiting dihydrofolic acid reductase like methotrexate, pemetrexate, etc. Then these may be purine analogs like 6-mercaptopurine, 6-thioguanine, cladribine, fludarabine. And these may be pyrimidine analogs like 5-fluorouracil, capecitabine, etc. These are S phase specific. Then M phase specific drugs, they will act on mitotic spindle. So they may inhibit formation of spindle like vincristine and vinblastine. and these drugs may inhibit breakdown of spindle like paclitaxel. Then coming to the most important non-specific. Among non-specific we have many drugs. Starting with the most important group is alkylating agents. Alkylating agents. The drugs in this category include, if bus not present, take my cycle. So these include ifosfamide, busulfan, nitrosoureas, procarbazine, temozolomide, melphalan, and cyclophosphamide. Now these drugs, special point to remember, first drug cyclophosphamide and ifosfamide, these can cause hemorrhagic cystitis as a side effect. Sometimes question is asked, what is the active metabolite of cyclophosphamide? It is 4-hydroxycyclophosphamide. That is the active metabolite. Then second important group of drugs in this category, these include platinum compounds like cisplatin, carboplatin, etc., oxaliplatin. Now among this cisplatin, special point to remember, it will sensitize the body to radiotherapy, radiosensitizer. So that means same amount of radiation can cause more toxicity if the person is receiving cisplatin. Then we have some miscellaneous drugs like bleomycin. Bleomycin is metabolized by bleomycin hydrolase, which is deficient in skin and lungs. So it can cause flagellated pigmentation of skin as a side effect. Whereas in the lungs, it can cause pulmonary fibrosis. Special point about bleomycin and vincristine are, these are marrow sparing. They do not cause bone marrow suppression. Now important adverse effect about these cytotoxic drugs, you can remember from a cartoon which we make like this. Smiling cartoon with a cap, ears. Then we can make the organs. These are the lungs, heart, we have liver, we have kidneys, we have urinary bladder. So the important adverse effects you can remember, that this ear look like C, so C means cisplatin. So cisplatin, it can cause ototoxicity. This also look like C, so cisplatin cause vomiting, which is highest among all the anti-cancer drugs. And kidney look like C means cisplatin can cause nephrotoxicity. Okay. Then this cap look like V, so V for vincristine. So vincristine, vinblastine can cause effect in the brain, which is the release of ADH, SIADH, and they are acting in periphery, leading to peripheral neuropathy. Then this lung look like B, so B for bleomycin and B for busulfan. They can cause pulmonary fibrosis. Then we have heart, which look like D, so D for doxorubicin and donorubicin and epirubicin. So these can cause cardiotoxicity, and you can remember from the name, their name contains ruby. All of them contain ruby in the name. So ruby dil le jati hai. So name start with D means dil le jati hai. They affect the heart. Then this liver look like 6. So 6 stand for 6-mercaptopurine. It is hepatotoxic. And only complete cycle in this, if you see cycle, so cycle means cyclophosphamide, it can cause hemorrhagic cystitis. And we can use mesna to prevent this hemorrhagic cystitis. Okay. So these are the important points regarding the cytotoxic drugs. Then moving to targeted anti-cancer drugs. Targeted anti-cancer drugs can be monoclonal antibodies. These are big, they need to give by injection. So monoclonal antibodies like we have cetuximab, rituximab, trastuzumab. Cetuximab is used in colorectal carcinoma. Rituximab is used for non-Hodgkin's lymphoma and chronic lymphoid leukemia. and trastuzumab, it is used in breast cancer. Trastuzumab is cardiotoxic also. Then one group of the monoclonal antibody recently formed is known as immune checkpoint inhibitors. Immune checkpoint inhibitors. The basic concept is that if this is a cancer cell and this is a T cell, so normally T cell is targeted to kill the cancer cells, but T cell is not killing a normal cell. The reason is that there is presence of certain receptors on the cancer cells also and T cell also, normal cell also. So if it is a normal cell, it is expressing programmed death, whereas receptor, whereas T cells contains programmed death ligand. So if this bind to T cell, then T cell will become inactive, so it will check the immunity that it need not kill a normal cell. So the cancer cells know that the T cell is not killing a normal cell, so they also start expressing this receptor. So when they start expressing this receptor, now T cell will become checked, so it will not be able to kill the cancer cell. So if we give a drug which will inhibit this interaction, now the T cell will not be able to check the immunity, so immunity become overactive and that will kill the cancer cell. Okay, so that is the new concept. So we have drugs which can bind to PD1 or PDL1. Now the drug which bind to PD1 and stop the immunity, these you can remember as penicillin. So pembrolizumab, nivolumab and semiplimab. Whereas the drugs which bind to ligand, they are remembered as LAD. This is ligand, programmed death ligand. We have atezolizumab, avelumab and durvalumab. So these can be used for many types of cancers. Particularly pembrolizumab and nivolumab are used in plenty of cancers, including Hodgkin's lymphoma, non-small cell lung cancer and many other cancers. Pembrolizumab is also used in endometrial cancer, whereas semiplimab is used for squamous cell carcinoma of skin. Atezolizumab and durvalumab is for urothelial carcinoma, whereas avelumab is for Merkel cell carcinoma. So these are the immune checkpoint inhibitors. So first group is monoclonal antibodies. Then second group of drugs, targeted drugs, they include tyrosine kinase inhibitors. Tyrosine kinase inhibitor, the name will end with the nib, and all of them are effective orally. Now some of the important tyrosine kinase inhibitors, one which is used for chronic myeloid leukemia, you can remember from IND, India में common है. So imatinib, nilotinib and dasatinib, they are used for CML. Imatinib is a drug of choice. Then we have some tyrosine kinase inhibitors used in lung carcinoma, lung cancer. So for lung carcinoma, we can treat after doing ECG. So erlotinib, ceritinib and geftinib used for lung carcinoma. Then we have tyrosine kinase inhibitor for renal cell carcinoma, remembered as PAS, pazopanib, axitinib, sorafenib and sunitinib. Then in a patient of hepatocellular carcinoma, we will say sorry, we cannot do anything. Sorry means sorafenib. In fact, sorafenib is now the drug of choice for hepatocellular carcinoma. Then for breast cancer, we use lapatinib. Lapatinib, you can remember, in the breast there is lump. Breast cancer, lapatinib. Then we have gastrointestinal stromal tumor, you can remember as SIR, sunitinib, imatinib and regorafenib. Imatinib is a drug of choice for GIST. So these are the important tyrosine kinase inhibitors. Then we have one group of drug called as proteasome inhibitor. These drugs used in multiple myeloma. The drugs ending with zomib. like bortezomib, ixazomib, carfilzomib. These are used in multiple myeloma. Okay, so these are the important anti-cancer drugs. Then the next topic is immunosuppressants. So important three group of immunosuppressant you should know. One are glucocorticoids. So we already discussed in detail in endocrine system. Second are NFAT pathway inhibitor. We are going to discuss this. And third group are basically monoclonal antibodies. Glucocorticoids we already discussed. The NFAT inhibitor, first of all, what is this pathway? Not NFAT, it is inactive in phosphorylated state. When dephosphorylation occur, it become active. Nuclear factor of activated T cell is the full form. So the substance which cause dephosphorylation is calcineurin. So after it become active, it will go to the nucleus and it start production of interleukin 2. Now this interleukin 2 will bind to its receptor and that will activate an enzyme called as mammalian target of rapamycin, which lead to immunity. So if we stop this pathway, we can stop the immunity. And the drugs are, they can inhibit calcineurin like cyclosporin and tacrolimus. They can inhibit interleukin 2 receptor like daclizumab and basiliximab. And they can inhibit mTOR like sirolimus. The most important are cyclosporin and tacrolimus. Both these drugs cause lot of side effects, like they are nephrotoxic, they are hepatotoxic, they are neurotoxic. Plus they increase everything, means they increase blood pressure, increase potassium hyperkalemia, increase sugar hyperglycemia. These are the adverse effects. The difference is cyclosporin, it cause hirsutism also, which is not caused by tacrolimus. Other side effects are same. Okay. Then third group are monoclonal antibodies. Particularly they are targeting some interleukins, like we have interleukin 1 blocker. It is called as anakinra. Anakinra, you can remember, kinra means interleukin receptor antagonist, used in rheumatoid arthritis. Then we have drug which can block interleukin 6 receptor. Interleukin 6 receptor antagonist is sarilumab. Sarilumab. So it is a monoclonal antibody against interleukin 6. It is used for rheumatoid arthritis. Then we have a drug called as co-stimulation inhibitor. Co-stimulation inhibitor, the drug is abatacept. It is also used for rheumatoid arthritis. So these are the important immunosuppressant drugs. Then moving to some of the remaining topics, like treatment of hyperkalemia. So this is topic is lot of questions are being asked from this. For acute hyperkalemia, one thing we can use is we can use insulin. Insulin and salbutamol are the two drugs which increase intracellular movement of the potassium. So basically sympathetic system, when it is activated, it stimulates beta 2. Adrenaline can stimulate beta 2. Salbutamol can stimulate beta 2, that increase intracellular movement of potassium. So we can use insulin glucose for acute hyperkalemia. Apart from this, for acute hyperkalemia, we can use calcium. Calcium basically will reverse the ECG changes of hyperkalemia. Then we have potassium binders. These are given chronically, oral therapy, when there is chronic hyperkalemia. Okay, so these are the important points regarding the hyperkalemia. Then we have drugs for erectile dysfunction. You can remember these drugs as PAP, erectile dysfunction. We have phosphodiesterase inhibitors. The drugs like sildenafil, vardenafil, tadalafil. Among these, tadalafil is the longest acting drug. Tadalafil is longest acting phosphodiesterase inhibitors, and these drugs should never be given with nitrates, otherwise severe hypotension can happen. Then we have L-prostadine. It is used locally, intracavernosus injection is given. We have alpha blockers, although these are not preferred nowadays. Then we have papaverin. Papaverine. This is also not commonly used nowadays. These are the drugs which are mainly used. Then lastly, chelating agents. So we have a chelating agent called as BAL or dimercaprol. It is used mainly for bismuth, arsenic and lead poisoning. बट वी नो कैफे में बाल होगा तो वो कैफे नहीं चलेगा. सो इट इज contraindicated in cadmium and iron poisoning. In cadmium and iron poisoning it is contraindicated. Then second is EDTA. The full form is calcium disodium EDTA. We know calcium is present in milk, so it is used for milk. Means manganese poisoning, iron poisoning, lead poisoning and cadmium poisoning. Now in lead poisoning, usually if it is severe, we use combination of EDTA with dimercaprol, means BAL. Okay. Then we have a drug called as D-penicillamine. It is used for copper poisoning. We have desferrioxamine and daferipirone. Desferrioxamine is used for, both of these are used for iron poisoning. Desferrioxamine is for acute iron poisoning, drug of choice, whereas for chronic iron poisoning we can use daferipirone, which is oral drug. Okay, so these are the important chelating agents. Lastly, we'll discuss the antidote of important drugs which are commonly asked in the exams. Organophosphate poisoning, the antidote is atropine. Benzodiazepine poisoning, it is flumazenil. Opioid poisoning, it is naloxone. Methanol poisoning, it is fomepizole. Paracetamol poisoning, it is N-acetylcysteine. Valproate, it is carnitine. And beta blocker poisoning, it is glucagon. Okay. So these are the important antidotes you must remember. So with that we completed our rapid revision. It's quite hectic, I know. So but I am hopeful that it will be helpful to you. So thank you very much.